আসসালামু আলাইকুম। এক্সিস্ট ডেন্টাল স্কুলের পক্ষ থেকে সবাইকে জানাচ্ছি স্বাগতম। আমি আনিসা তাসনিম, বর্তমানে হলি ফ্যামিলি রেড ক্রিসেন্ট মেডিকেল কলেজে তৃতীয় বর্ষের শিক্ষার্থী হিসেবে অধ্যয়নরত আছি। এক্সিস্ট ডেন্টাল স্কুল সকল শিক্ষার্থীদের জন্য আয়োজন করছে ঘরে বসেই পড়াশোনা করবার সুযোগ। করোনাকালীন এই সময়ে আমাদের জীবন যেন একেবারেই অচল হয়ে গেছে, কিন্তু থেমে নেই এক্সিস্ট ডেন্টাল স্কুল। সেই সাথে আয়োজন করছে বিভিন্ন ওয়েব সেমিনারেও। তেমনি ভাবেই আজ আমাদের সাথে যুক্ত হয়েছেন আমাদের দেশের বিভিন্ন গণ্যমান্য শিক্ষকগণ, এবং আমাদের সাথে নেপাল থেকে যুক্ত হয়েছেন আরেকজন শিক্ষক। জি দর্শক, আপনাদের উদ্দেশ্যে বলছি, আজ আমাদের ওয়েব সেমিনারের বিষয় হচ্ছে টুথ প্রিপারেশন, টিস্যু ম্যানেজমেন্ট, টেম্পোরাইজেশন, টিস্যু ইমপ্রেশন ইন ফিক্সড পার্শিয়াল ডেন্চার। আমাদের সাথে সবাই যুক্ত হন এবং কমেন্ট সেকশনে আপনাদের যা জানার থাকে আমাদের শিক্ষকদেরকে জানিয়ে দিন। আমি পরিচয় পর্ব করিয়ে দিচ্ছি। আমাদের সাথে চেয়ারপারসন হিসেবে যুক্ত আছেন প্রফেসর ডক্টর আবুল কালাম আজাদ, যিনি হেড ডিপার্টমেন্ট অফ প্রস্থোডন্টিক্স, গণস্বাস্থ্য সমাজভিত্তিক মেডিকেল কলেজ। আমাদের গেস্ট অফ অনার হিসেবে উপস্থিত আছেন প্রফেসর ডক্টর হুমায়ুন কবির বুলবুল স্যার, যিনি ঢাকা ডেন্টাল কলেজের বর্তমান প্রিন্সিপাল। আমাদের সাথে স্পিকার হিসেবে আছেন ডক্টর দীপক থাপা, যিনি ফ্যাকাল্টি মেম্বার ডিপার্টমেন্ট অফ প্রস্থোডন্টিক্স, কান্তিপুর ডেন্টাল কলেজ, বসুন্ধরা, নেপাল। আমাদের কোঅর্ডিনেটর হিসেবে যুক্ত আছেন ডক্টর অনুপম পোদ্দার স্যার, যিনি অ্যাসোসিয়েট প্রফেসর অ্যান্ড হেড অফ দ্য ডিপার্টমেন্ট পেরিওডন্টোলজি অ্যান্ড ওরাল প্যাথোলজি, ঢাকা ডেন্টাল কলেজ। আমাদের মডারেটর হিসেবে আজ সাথে আছেন ডক্টর সাইফুল ইসলাম স্যার, যিনি অ্যাসিস্ট্যান্ট প্রফেসর ডিপার্টমেন্ট অফ প্রস্থোডন্টিক্স, ঢাকা ডেন্টাল কলেজ। আমাদের প্যানেলিস্টে আজকে 4 জন মেম্বার আছেন, যার মধ্যে প্রফেসর ডক্টর জাকির আহমেদ শাহিন স্যার আছেন, যিনি হেড ডেন্টাল ইউনিট, ঢাকা ন্যাশনাল মেডিকেল কলেজ। প্রফেসর ডক্টর খুরশিদা তানজির, যিনি হেড ডিপার্টমেন্ট অফ প্রস্থোডন্টিক্স, সিটি ডেন্টাল কলেজ, ঢাকা। আমাদের সাথে আরো দুজন প্যানেলিস্টে যুক্ত আছেন ডক্টর মোহাম্মদ আব্দুল আওয়াল, অ্যাসিস্ট্যান্ট প্রফেসর অ্যান্ড হেড ডিপার্টমেন্ট অফ প্রস্থোডন্টিক্স, রাজশাহী মেডিকেল কলেজ, ডেন্টাল ইউনিট। এবং সর্বশেষ আমাদের সাথে যুক্ত আছেন ডক্টর পিয়ারুল ইসলাম স্যার, যিনি ডিপার্টমেন্ট অফ প্রস্থোডন্টিক্স হেড, ঢাকা ডেন্টাল কলেজ। সকল স্যারকে জানাচ্ছি আন্তরিক শুভেচ্ছা এবং আসসালামু আলাইকুম।
সালাম।
স্যার, আপনাদের অসংখ্য ধন্যবাদ এক্সিস্ট ডেন্টাল স্কুলের পক্ষ থেকে এত ব্যস্ততার মাঝেও আমাদেরকে সময় দেওয়ার জন্য। আমি আমাদের মডারেটর ডক্টর সাইফুল ইসলাম স্যারকে অনুরোধ করব আজকে আমাদের ওয়েব সেমিনারটিকে সম্পূর্ণভাবে পরিচালিত করবার জন্য।
Thank you very much. Welcome to today's webinar. Assalamu alaikum to everyone. Already today's speaker, chairperson, guest of honor, and all the panelists are introduced by the introducer. First of all, I thanks all of you to present here. Today we will present a very important topic about which is used in our daily chamber practice, and Dipak Thapa will present all the things. And first of all, I request our chairperson, Professor Dr. Abul Kalam Azad sir, to tell something about today's webinar.
Thank you, Saiful. I have get an opportunity to welcome all the panelists and speaker and other. Our principal, Dhaka National College, Humayun Bulbul. Giving first of all, I want to thanks the Humayun Bulbul. Yes, in this connection, I want to thanks to guest of honor, Dr. Humayun Bulbul, Principal, Dhaka Dental College, to join with us. And another thing, he is a dynamic and Secretary General for Bangladesh Dental Society, as because he is taking a different problem in this, facing the problem for dental surgeon in different way and different times. I have recently seen that he is taking a step there, the periphery of the Upuzela or others area of the dentistry, where that taking some creating some problem of the dental surgeons. That's why I am giving many thanks to Dr. Humayun in this connection. Now I want to, it is a great opportunity to learn, exchange our knowledge from each other in this COVID problem or pandemic situation. So today's subject is to tooth preparation and management, temporization and impression, fixed partial denture. The speaker is Dr. Thapa, Faculty of Member, Department of Prosthodontics, Kantipur, Dental College and Bosundara, Nepal. Now we come to a point of this subject. Today's moderator, SAIFUL ISLAM, and others panelists, all these are come here and welcome to these sessions. But we think it is very easy to tooth preparation, so we asking the lab assistants to tooth preparation and impression in our country and in our the respects. But it is very unavoidable situation, but no tissue management and temporization. But it is not easy to work, so we cannot doing ourselves in many cases. I have seen in different country when they are learning, they are using the typhodont, where they are taking the different point of the tooth preparations. But in this country, in even the Bangabandhu Sheikh Mujibur Medical College, university, they are also not taking the direct working on the patients. Not before going to the patients, they are not taking any typhodont work or any other exercise work. So it is very essential to improve our different tooth preparation situation, where we can use this typhodont or any other things, where we can do students or learner can take this, then they will work after this learning on the typhodont or any other things. Then they will go to the patient work. That's why I have seen in these connections, the people are doing tooth preparations and setting a crown over there. And after taking a long time or 6 or 7 months, coming to the different problems, either caries in the distal tooth or caries in the mesial tooth. So it is very difficult to solve these problems and making another problems for these patients. So we are thinking that it is better to take something. Today we will learn from the Dipak Thapa from the Nepal doctors, who will be learn. We will learn from him in these connections. Please, thanks to all and to welcome to all to start our speaker his topics. Thank you.
In addition to Azad sir, I also thank our principal, Dr. Humayun Bulbul sir. I really lucky to have a principal like him, and I appreciate this, that though he is always busy with multiple works, but always he gives us time. And in this basic dental school bond, always he is giving his valuable time. And it is our passion to it will be our passion to be like him and all the dental surgeon in Bangladeshi dentistry. I am telling that the Humayun Bulbul are make a new era. All the dentists are coming forward, and in this session, our Professor Dr. Asstt Professor Dr. Anupam Podder sir, he is also doing a very good job in this corona situation. He taken multiple steps for dentistry, and now he is a international figure. Now I am going to today's presentation. Along with Azad sir, I am also telling something that tooth preparation is our daily basic work. All the dental surgeons should have know this. And temporization in our situation or our country, or not only in our country, in Indian subcontinent, all the doctors try to avoid the temporization. But we know, the postodontists know the value of the temporization. Now coming to the today's speaker, Dr. Dipak Thapa, who is now a leading postdodontist in Nepal. I know that, and you will be grateful to hear that he completed the BDS degree from City Dental College, and he is our batchmate also. And after that, he completed MS degree from Bangabandhu Sheikh Mujib Medical University. and now leads the Prosthodontics department in Nepal, and as a faculty in Department of Prosthodontics, Kantipur Dental College and Hospital, Bosundara. Now I am going to Dipak Thapa for and requesting Dipak Thapa to start the session.
Thank you very much.
With the permission of the chair.
Yes, start please, Dipak Sharma. Thank you.
Thank you very much. Good evening, namaste and assalamu alaikum. Before I start, I would like to request everyone, please just mute your mic so that there will be no any disturbance during this session. So I request everyone to please mute the mic, then there will be no disturbance. So I think now I have to go to the share screen, and so I'm quite new to this.
Before starting, I would like to say hello, Dipak.
Yes, all right. Hello.
Thank you. Start, please.
I'm quite new to this this technology, this StreamYard. So I don't know whether I'll be able to conduct it smoothly or not.
Smoothly.
So now, how do I start?
Yes, you can start.
You can start.
Can you guys see my slide?
No.
No. Yes, no.
Yes, wait.
Yes.
Okay.
Can you see me now?
Yes, yes.
Okay.
Okay. Now, with the permission, I would like to start. Now, it's before I start into my topic, I would like to thank all the organizing team and especially Dr. Anupam for asking me this to talk today here. And today I'm here with a huge topic: tooth preparation, tissue management, temporization, and impression. It's a quite huge topic, and now to talk in this all the field within an hour is it's quite impossible. But I will try my best to make it as short and sweet as possible. And while this tooth preparation, before I start tooth preparation in my patients, what I make sure that first I discuss the tooth material, this restorative materials with my patient, because that is the most important thing. Because after deciding this restorative materials, then only we should plan for the tooth preparation. And in my day-to-day practice, I practice a lot of this materials in my daily practice. So one of the oldest material, we all know that the gold is one of the oldest material, and very few patients can afford this. But still, this is one of the best material, I would say, for the posterior region. And one of the reason for this is the burnishable margin. You can burnish the margin to adapt it to the tooth very nicely. And another advantage of this is for the last standing tooth. If my patient has no problem with the financial aspect, then I would always love to use this material on the last standing tooth, because one of the greatest advantages of this material on the last standing tooth is that this will wear more easily than the natural enamel. So on the last standing tooth, if we can afford this one, then it's a very good one of the great advantage for the patient. But due to cost, very few patients can afford it. And another option for my patient for crown and bridge is another is metal. And we all know that in our part of the world, patient wants something that lasts for many years. Patients seek for warranty or something like that. And that condition, I think this metal crown is the best and for them. And also this the tooth preparation is very conservative. And the third one is metal ceramic. I think we all practice this materials very often in our clinic. Most probably this is the materials that has the highest long-term study of success study. And this is a very wonderful material, because here there's the strength of the metal and the aesthetic of the ceramic. So this is excellent materials. And still when my patient asks for a long span bridge, when I'm going for a long span bridge, say there are 4 pontics, And that condition, still this is the material of choice, because even though there is other materials, people are using that, but I still find confident with these materials. If the Pontic is, the number of Pontic is 4 or 5, in that condition, I think metal ceramic is the best. Still, this is the best material. And another material we can talk is like this indirect composite. I don't know whether you guys are practicing it this or not, but very few of my friends are, they love this material very much, indirect composite. And one of the advantages of this material is that you can easily repair this. You can repair this material's chair side. So because of that advantage, everyone is, few of my friends are, they love this material very much. But I am not very great fond of these materials. The one of the advantage of this materials is like if you are putting a crown over the implant, in that condition, this composite, indirect composite, is very good. It adds, it's quite resilient materials. So in that context, this is very good materials. It will act as like a periodontal ligament for the implant restoration. So this, having this materials over the implant, is very good for the implant. And then another materials, though it is very quite old materials, very rarely available, but nowadays this is available in Nepal again, in the block form. So you can mill it. In the past, it was this manipulation was very difficult, so people almost forgot this material. But this is back again with the milling form. So if you have this block, then you can mill it. This is not a strong materials, but this is one of the best aesthetically pleasing looking restorative materials. So if someone wants laminate, then I do recommend this material. But for me, my choice would be lithium disilicate. When aesthetic is the most important for my patient, when aesthetic is high in demand, then in that condition, my material of choice will be lithium disilicate. I love this material very much. And one of the one of the best part of this material is that you don't need to mill it. You can mill it, but even if you have a lab in your premises, in your clinic, and if you have a pressable furnace, then you can press it also. So the press, you can press it, you can mill it, and you get this in different shades, from A1 to say D3. You get it in every shades. You also get this in different this opacity and different translucency. So this material is very easy to work with. So and another advantage of this lithium disilicate is like once you bond with this metal with the tooth, you'll achieve this monoblock effect. That means this restoration is going to protect your tooth. At the same time, the restoration strength increases a lot once it is bonded. So that is another greatest advantage of lithium disilicate. Wonderful materials, very aesthetically pleasing, and far stronger than feldspathic porcelain. The strength of feldspathic porcelain is like 60 to 90 megapascal, this compressive strength. But lithium disilicate, if it is milled, then it is 360 megapascal. But if it is pressed, then it's like about 400 megapascal. The compressive strength is very high. So you can practice this materials for brace, anterior brace, or posterior crown, anterior crown. It's excellent material. And this aluminum oxide, the next one is aluminum oxide. Actually, this aluminum oxide has been slowly getting obsolete. It's not nowadays not available in the most of the part of the world. It's getting slowly obsolete, but it's available in my lab. I found these materials very useful. The main important about this material is like this is far stronger than lithium disilicate, but little less strong than zirconia. The strength is from 700 to 900 megapascal. But the most important thing about this material is that if you have a normal metal ceramic facility in your lab, then you can easily adopt this system in your lab. Just you need to buy this aluminum oxide and the layering ceramic. You don't need to spend a lot of money for milling and all those things. So this, in that aspect, this material is very feasible. So I got this material from different part of the world, and I collected this, and I'm doing it for 3-unit breeze or 4-unit breeze in the anterior as well as in the posterior aspect. Very wonderful materials, strong enough and easy to fabricate. And this is like a glass infiltration system that I am using it here. But the problem is like the materials is very rare to be available. So, after all, the whole world is running after the zirconia, so this material is getting slowly obsolete. Now, zirconia, we all know that zirconia is getting popular day by day, and almost not only the dentist, this marketing team, they want us to move towards the zirconia. Everyone is after zirconia. You can, there's a lot of indication of zirconia. You can go for a brace crown. You can go for you can meal into a bar and go for a long span implant supported brace. You can use it everywhere, if you are really using this zirconia, then there are few signs that you need to understand about the zirconia. Because there are lots of different types of zirconia in the market. They are not all equally strong. Whenever we hear this term zirconia, everyone think that the strength is 1300 megapascal. No, only the tetragonal zirconia, the strength is 1300. The rest of the zirconia that nowadays available in the market, which are aesthetically very pleasing, their strength is hardly 600, 700 megapascal. So what we need to understand is, if this zirconia looks aesthetically very superb or very pleasing, then that means that zirconia doesn't have the strength. If your zirconia looks a little opacious, whitish, in that condition, that is a tetragonal zirconia. So in zirconia, if it is strong, it doesn't have the aesthetic. If it is aesthetically pleasing, it doesn't have the strength. This is very important to understand, because there are two types of zirconia. One is cubical zirconia, one is tetragonal zirconia. Tetragonal zirconia for strength, cubical zirconia for aesthetic. So you need to understand this thing before you go for jump for the zirconia. But that really is very good materials. And in zirconia, you can go for a monolithic posterior crown, or you can layer it, but the layering is not strong like metal ceramic. The bond between metal and ceramic is very good, but the bond between the zirconia and the layer ceramic is not that good, not that strong. So whenever you go for zirconia, try to go for monolithic, not for the layered zirconia. Now, why we need to decide about the materials before we start tooth preparation? Because for each materials, the tooth preparation will be different. There will be some variation. So the variation will be in amount of tooth reduction. If you are using, say metals, if you are preparing a tooth for metal or for zirconia, your tooth preparation will be minimum. You don't need to do a huge tooth preparation. Your tooth preparation will be more conservative. But if you are doing a tooth preparation for, say, feldspathic porcelain, then in that context, you have to prepare tooth quite big. It's about 2 millimeters. So the amount of tooth reduction will be different for each different materials. Similarly, the type of margin. Some of the restorative materials demand for solder. Some of the restorative material demand for bevel or say, short chamfer. So the type of margin is different for different materials. So you got to understand this before you prepare the tooth for the particular restorative materials. Similarly, the location of the margin is also going to be different. Because if your material is very aesthetically pleasing, then you don't need to hide that margin substantially. No need to go for substantial margin until and unless there is some carriage or you need that extra grip for retention. Otherwise, if it is, say, for metal ceramic, you are preparing a tooth and you are having a metal margin, in that condition, you might need to hide it just beyond the gum. So you might need to take your margin substantially. So that will be the variation. Similarly, the line angle. Normally, in all cases, we recommend to rounded the line angles. All the line angles has to be rounded. But if you are working with metal or metal ceramic, maybe that is not going to be a big problem, even if you miss some places. But if it is aluminum oxide or zirconia or especially feldspathic porcelain or Emax, in that condition, if you forgot to rounded those line angles, then it will be very punishing because your restoration will not last even a few days. So that is very important. So line angle has to be rounded for weaker materials. Similarly, the degree of taper. We have been taught in our school to prepare our tooth as parallel as possible. So for metal and metal ceramic, that's okay. But if you are preparing a tooth for, say, for example, Emax, and where you are going to use composite as a luting cement, in that condition, you do not want that complete parallelism. There you may need to be 12-degree or 22-degree taper. So in that way, when you are using resin cement, when you are going to burn the restoration to the tooth, in that condition, don't go for a strict parallelism. It's not good. It's not good for the sitting will be difficult, and it's not good for the restoration also. But if you are working with the metal ceramic, parallelism is better. So that's the basic difference. So now let's talk about the factors that affect the tooth preparation. So one we have already discussed, that is the strength of the dental materials. If your materials is strong, if your materials is very strong, then you don't need that extra space, or you don't need that extra preparation to thicken the restorative material. So you can have a conservative tooth preparation. If your material is weak, in that condition, say for example feldspathy porcelain, then at least this overall reduction has to be about 2 millimeters. So you need more thickness for the strength of the materials. So similarly, the color of the core metal is another importance. Say for example, if you are preparing a metal tooth for metal ceramic restoration, and the metal framework is from say base alloy, in that condition, this base alloy is very dark in color. So to hide that darkness, that blackishness, you need little more extra tooth preparation, so that you will have a little extra thick, this like opaque and then dentin over this metal frame. But if you are if you are making that restoration with the gold, say for example precious gold over the underneath the porcelain, that in that condition, that warm gold has a warm color, so you don't need that extra thickness to hide the color of the gold. So that is the basic difference. So if your color of the core material is tooth friendly, then a little less preparation is okay. But if it is completely dark in color, in that condition, you need a little more extra tooth preparation. Similarly, this another point is going to be opacious or translucent. Some of the materials are very opacious, some of the materials are very translucent. So accordingly, you have to plan which materials you are going to use. Say, for example, so when I'm using this lithium disilicate, they are available in different opacity. Say, for example, medium opacity, high opacity, low translucency, and high translucency. At least they are available in 4 translucency. So if I am going to use this highly translucent core materials, in that condition, I don't need that. I don't need to prepare the tooth heavily, because my material is already translucent, but the color of the tooth is very good. In that context, I don't need to hide the opaciousness of the core. But if I'm using this highly opacious material, because my tooth is dark in color or it's blackish, to hide that, I'm going to use opacious opacious ingot. In that condition, I need extra room for the layering porcelain. So we need to prepare tooth a little bit more. And similarly, monolithic or layering is the same, almost similar point. If you are using a monolithic crown, then a little less tooth preparation is okay. But if you are going to layer it, then for this layering ceramic, you need extra space, and so you need to prepare a little bit more. So this is the monolithic crown. So for monolithic, you don't need extra preparation. But if you are going to layer it, then in this case, you are going to layer it. So in this case, you need a little more extra preparation in the incisal aspect. Another important point to be remember is the color of the tooth. This color, if your tooth is discolored, if the tooth is dark blackish in color, if you are working with metal or metal ceramic, in that condition, this point is not important. This point doesn't have any validity. But if you are working with the emax or feldspathy porcelain, in that condition, if your tooth is dark, it's already discolored. In that condition, you need little extra preparation, more preparation, so that your material's thickness will be increased, and it will be able to hide the color of the inner tooth very effectively, nicely. So your restoration will look more natural in that condition. So whenever your tooth is discolored, a little more tooth preparation if you are working with metal fluids. Similarly, in every condition, the anterior teeth demands more aesthetic, and the posterior teeth demands for this strength. So whenever more aesthetic is more concerned, you need little more tooth preparation, about 2 millimeter incisal, like that. So whenever aesthetic is in high demand, and another important point is whenever aesthetic is high demand. Sometimes what happens is like the adjacent tooth is highly aesthetic, like this picture. I don't know whether you can see it clearly or not, but if you see this picture nicely, then there you see different layers of ceramic there. There's bluishness, there's milky, there is a gradient, this and the color of this incisal is slowly decreasing. The translucence is decreasing slowly downwards as you go to cervically. So there are lots of different layers of ceramics over there. So if your adjacent tooth is of this type, so definitely you want your restoration to be to match the same aesthetic. In that condition, maybe sometimes 1.5 is not enough, and you need to do 2 millimeters of tooth preparation. So that is how you have to take tooth preparation according to your demand. And this term is not that very important, but still you got to remember it. If you are milling, if you are, say for example, Emacs, if you are working with the Emacs, and if your lab is going to mill it, so the milling are more stronger. The milling is less stronger than the pressing one. So when your restoration is less stronger, maybe a little bit of extra thickness is good. So whenever you are milling it, little more preparation. If you are pressing it, maybe little less is sufficient. And also another important point is luting cement. We all know that luting cement requires some space between the restoration and the tooth. And we all know that nowadays there are so many different types of luting cements available in the market. Say for example, glass ionomer, resin modified glass ionomer, and then this composite. So if you are using composite as a restorative materials, then it has a little less flow in compared to glass enomer or resin modified glass enomer. So it will take little more space in compared to other. So whenever you are using thicker luting cement, you might need a little more space for that. So you need to prepare a little bit more. So now let's come to this tooth preparation. So if you are preparing a tooth for metal crown, we know that in the textbook there's some recommendation. We need to remember that. So for metal crown, normally the overall reduction should be about 0.5 to 1 millimeter. And if, we all know what is functional cusp bevel. I will explain it later on. But for the time being, the functional cusp bevel area is the area where the maximum force will be exerted when you are chewing it. For example, if it's a lower mandibular teeth, posterior teeth, and then in that context, the buccal aspect of the buccal cusp is the functional cusp bevel area. So that is the area where the maximum force will be exerted. And if it is a maxillary teeth, the maxillary posterior teeth, and then in that context, the palatal aspect of the palatal cusp is the functional bevel cusp area, and that is the area where the maximum force will be exerted. So we want our restoration to be a little thicker on that area so that it won't deform when the patient bites something very hard. So for that purpose, we need a little extra preparation on those areas. So functional cusp bevel area, it should be at least 1 millimeter or slightly more than 1 millimeter for metal crown. And for margin, regarding margin for metal crown, we don't need a very thick margin. So sometimes short chamfer is good. It's easy to prepare. And even if you are used to prepare the bevel, then it's fine. Sometimes knife edge is also okay, but feather edge and these things, I don't recommend that. But short margin, short chamfer and bevel is the, I think that's the most recommended margin for the metal crown. And now let's go to metal ceramic. So if we are preparing a tooth for metal ceramic, then we must remember this thing, that overall reduction has to be 1 to 1.5 millimeter. And if it is more cervically, then it will be 1 or little less than 1 meter. But as you come towards the incisal edge, then it has to be little more, say 1.5 millimeter. And on the incisal reduction has to be 1.5 to 2 millimeter according to the aesthetic. And if it is a metal ceramic crown for the posterior tooth in the functional cusp bevel area, then definitely go for 2 millimeter, 1.5 to 2 millimeter, because there we need the thickness of 0.5 to 0.6 for the metal, and then the rest 1 millimeter for the ceramic. If it is thin in that condition, then there will be a problem. I have seen many technicians, what they do is they prepare the metal to almost zero. They make it very thin so that they will have an extra space for the ceramic. But the problem is that if your substructure is very thin, under masticated loading, this metal will deform slightly. So once the metal starts to deform, or even if it tends to deform, in that condition the ceramic will chip off. So that is the one of the common reason why our ceramic chip off from in the posterior aspect. So we need to make sure that the thickness of the metal in this load-bearing areas should be more than 0.5 millimeter. So that's very important. Similarly, in the interior teeth, this incisal bevel has to be tilted palatally. So we need to prepare this incisal bevel. And for metal ceramic, normally I prefer long chamfer on the labial aspect and short chamfer on the palatal aspect. And if you guys want to prepare shoulder, then it's okay. But in compared to shoulder, long chamfer is far easy to prepare, and it's far more conservative. So I do recommend the long chamfer rather than the shoulder. Shoulder is if you are preparing a tooth for colorless metal ceramic restoration. This means you are going to design the margin completely with the ceramic. So in that context, you need this shoulder, and the shoulder portions are available to design that, to create that margin. But in other cases, I think the long chamfer is the best for in the labial aspect, and short chamfer in the palatal aspect. And whenever possible in the palatal aspect, go for a metal margin. Don't ask your lab to have that ceramic on the metal aspect, on the margin aspect. Metal margin is the best in the palatal aspect. This is one of the most difficult to prepare. To prepare a tooth for lithium disilicate is one of the most, I say, it's most challenging, and you need more attention and more focus when you are preparing a tooth for lithium disilicate, because you can't do any mistake in lithium disilicate, because this material is not that strong. So if there is any lack of say insufficient preparation, then your restoration will fail. So overall reduction is 1.5 millimeter. And for incisal reduction, go for 2 millimeter. If it is for the posterior tooth, you are preparing this tooth for the lithium disilicate, then in the occlusal aspect and functional cuspidal area, go for 2 millimeter for this extra strength. Margin 360-degree long chamfer, both palatal and labial and the proximal 360-degree. You have to prepare a long chamfer margin. And the most important is you need to this rounded all those internal line angle. It should be rounded. And sometimes what happens is you can press this materials even up to 0.3 millimeter thickness. So even if your margin is short chamfer, then you will be able to press it, but you will lose the strength. So if it is say for example, if you are preparing a tooth for say laminate, so if you are practicing laminate and if your preparation is for laminate, in that condition, if the strength is not going to be directly on the restoration, in that condition you can go for 0.3 millimeter of margin, or even in some areas if it is thin, so it won't be a problem. But if it's a crown, if it's a brace, then you need to little bit more preparation for the strength of the materials. So now let's move to zirconia. So most probably, I think you guys, everyone is practicing zirconia, but zirconia is not my favorite material. But I know every dentist, they love to work with zirconia because this gives a little more money to the dentist. And for zirconia, yes, it's a very conservative tooth preparation. 1 millimeter is enough. It's you can compare this preparation with the metal. Slightly little more than metal is enough. So here you can go for a short chamfer or long chamfer. The difference will be if you are preparing it for the tetragonal zirconia, then go for a short chamfer. But if you are using for aesthetic zirconia, that is cubical zirconia, in that context, you go for a long chamfer. And this line angle has to be rounded, and you can build it like 0.5 millimeter up to 0.5 millimeter. So even in some places, if your tooth preparation is a little less, your lab technician can create a nice restoration with this, because you can mill up to 0.5 millimeter, not less than that. So if you see this picture, then you will have a little bit of idea about what would be the difference in the tooth preparation. So the first one, you can see this one, it's for metal and zirconia. So most conservative tooth preparation, very nice. You need this very short chamfer is prepared throughout the 360 degrees short margin and short chamfer. And if you see the PFM, this is a portion fused to metal. There in the labial aspect, you need a little more, little thick margin. So that is a long chamfer. And in the lingual aspect, or in the lingual or palatal aspect, you can go for short chamfer, but in the picture it's all 360-degree long chamfer. And if it is for all ceramic materials like feldspathic porcelain or Emax, then it needs to be margin needs to be little wider, and that's 360-degree solder or chamfer. Now, if you are preparing, if you are if you are preparing a tooth for crown and bridge in your clinic, then I guess that you have all understood this principle of tooth preparation. This is very important topic. What I do recommend is, like, even though we have passed our PDS or MDS, but in a certain time we must go through the book and recapture all those information. So it's very important. So every year try to go through this chapter if you love to work if you love to do the tooth preparation. So this biological consideration, mechanical consideration, aesthetic consideration, you got to understand each and every step, each and every words of this what is written in the book. But I'm not going to start this one. I'm not going to bore you because we have already read it a long time back, and so I guess no theory today because I don't have time. Only practical aspect we'll discuss, but it's very important. So now let's talk about this armamentarium. If you really want your tooth preparation to be very nice and perfect, then you need to have all these armamentarium in your tray. And my choice, just like most of the tooth preparation, almost 60-70% of my tooth preparation is done with that round end taper diamond burr that you can see in this black. This is the size of the burr I prefer, and I use Sofu burr, and this size is in Sofu we call the number is 106. So this is the burr I love. Most of my friends criticize me why you are using such a huge burr. The advantage of using this huge burr is your preparation will be smooth. This huge burr doesn't mean that this is to cut the extra. No, we are not cutting to the work with the huge burr. The advantage of this huge burr is your preparation is going to be smooth. Your margin will be smooth. If you just use the half of this width of this burr, you can create a nice, smooth this long chamfer with this burr. So I love this burr very much. And another is like this one, the second one over here in the red band. This is also a round end taper burr, and this I use for proximal aspect, in the proximal aspect or in the lingual aspect where I need to reduce the tooth a little less. In that area, I prefer this smaller size burr. And those who wants to go for this flat, this shoulder preparation, for them they need this flat end burr. And this flat end taper diamond burr is for shoulder. And I'm not a great fan of this shoulder preparation, so normally I don't use this burr. And this American football burr, I use this on the occlusal, the posterior tooth, as well as especially I use this burr on this lingual concavity of the maxillary anterior or the mandibular anterior teeth. And this end cutting burr, we call this end cutting burr, and this is end cutting because it has the diamond only in the tip of this end cutting burr, and this rest of the shaft, this plain burr, they don't have any diamond over here. So end cutting burr is to finish the margin, and that it will finish the shoulder that you have prepared. And if you want to take that shoulder little subjectively, then this burr will be very handy. And another important burr is needle shape burr. So this burr I use to break the contact whenever I have to start my proximal tooth preparation. So in the beginning, I use this burr to break the contact, and once the contact is broken, and then I use this little smaller than this burr, this round end taper burr, to widen that gap. So, and after the tooth preparation is done, so this is very important. Explorer and periodontal prop. This is very important thing, and you need to have this in your tray. With the Explorer, what we do is you feel the margin. Don't think that by seeing you can judge the margin. No, you need to feel it. So with the Explorer, you feel the margin, whether you have created it or not. With the Explorer, you feel it. When you are running your Explorer on the margin area, you just give a little bit pressure, this cervical pressure. And if there is some resistance, if the burr is not going downward, that means you have created a margin. So to see whether there's a margin or not. To feel whether there's margin or not, you need this explorer. And at the same time, once you've the explorer, you feel the margin on all 360-degree. And at the same time, you also feel the continuity, whether the margin is continuous or not, and whether it's smooth or not. So this has to be felt with the explorer, not with the eye. And at the same time, we also need this periodontal probe. Especially, I recommend this for the beginners, and because this helps you to how much tooth reduction you have done. Whenever we do the tooth preparation, we prepare different this depth grooves and guides, and that condition we have to measure those the depth of those grooves and guide, whether it's 1.5 or not, whether it's 1 millimeter or not. You have to check it before you continue with the further tooth preparation. And this hatchet and chisel, these are hand instruments. Many textbooks recommend this to finish the margin, to remove the overhang enamel. But I'm not a very great fan of this hand instruments, and I rarely use it. But it's always the textbook always recommend these hand instruments. Now let's come to the sequence of tooth preparation. This is the sequence that we find almost in every textbook, and we need to follow this strictly. Always prepare your, always start your tooth preparation with either incisal or occlusal reduction, and then start from the incisal reduction. And if it's supposed to start from the occlusal reduction, this is very important. Sometimes my student asks me, so why is it so important? Why can't we start with the buccal, or we do all the axial surfaces like buccal, proximal, lingual, and then come to the occlusal? What's the problem if you can do it properly? The answer is like, once if you start from the proximal or from the buccal or lingual aspect, and at the end if you reduce the incisal, you will not be able to maintain this parallelism. Sometimes you will be over taper. So if you do the occlusal or incisal reduction, now whatever height is remain, so now you have to make parallelism within that height. So it's always safe to start incisal or occlusal reduction, and then from the remaining tooth structure you have to achieve that parallelism. So that's the main reason why every textbook recommend incisal and occlusal reduction first. And after that, go for a labial or buccal reduction, and then proximal, and then the lingual or palatal reduction. And after that, finishing. That's the important thing. So, and then finally, evaluation. So now let's start with the incisal reduction. So this is the way I do, and most of the textbook also asks us to follow this one. So say if I'm doing the incisal reduction, so first of all, I have already decided whether this tooth preparation is for metal ceramic or for say Emax or for feldspathic porcelain or for zirconia. I've already decided it. So I now know how much would be the final tooth reduction. So accordingly, now I will make this depth group, and this depth group has to be just 0.2 to 0.3 millimeter less. So I'll make these groups like this, and then I'll measure with the perio probe, and whether it's of that sufficient depth or not. And then after checking it, then I'll finally reduce the incisal edge. And I use the round end taper bar for this purpose. And once this is reduced, then if you are working with this posterior tooth, and then we start from the occlusal reduction. So in the same fashion, we already know which metals we are working with, and how much should be the depth group, and how much should be the functional cuspidal area. We already know this, and then we start making this depth group. Sometimes I recommend my student to make these groups with the help of round burr. So with the round burr, it's very easy to prepare these groups. I ask my student to use 2 millimeter diameter round burr, and with the 2 millimeter diameter round burr, they make these groups. And the most important thing here is like we are reducing the occlusal surface, but we have to extend this to the functional cusp area. This functional cusp reduction comes within the occlusal reduction. This is very important. Don't think that we will do this thing during the labial reduction or during the palatal reduction. No, this has to be done within the occlusal reduction. So once after you reduce it, it should be like this one. You make a group. We have already made this group on this medial fossa, distal fossa, and then you have extended it to the cusp as well as on the functional cuspidal area. And then after the tooth reduction, it has to be like this. So this area is the functional cuspidal area. So this is the area where maximum force will be exerted. And this is the area where we need to prepare to little more than other area. So this is very important. Don't forget this functional cusp well. And I have seen many clinicians, those who are not in academic, they forget this term, this functional cusp well, and they during their preparation also they forgot this thing. Either they make the tooth all flat, or they just forget this functional cusp area, and they prepare in this area very little. So the problem is your ceramic or your metals will deform very easily. So that is the area where we need maximum tooth preparation, functional cusp well. So if you see this, this is the tooth preparation I have done on the phantom head, and this is the area that is phantom head. Sorry, this is the area that I have prepared a group in the functional cuspidal area. That's a maxillary tooth and maxillary first molar and maxillary is first premolar, and that is the area on the parallel aspect that I've extended. That is the functional cuspidal area. So that is very important to. So how do I do is like this. Normally I ask my student with the round burr, with the round 2 mm round burr, they make a small hole there, and then that they will extend it to this side. They start from medial and they will extend the groove to the distal fossa, and with the same burr, and then they will extend those groove. They will make the grooves on this like a triangular ridge, and then between the two cusps. So they will make lots of groups, 3 or 4 groups, and they will also make this on the functional cuspidal area, and they will check it with the perio probe, and then finally they will do the occlusal reduction. So this will be how this is the picture how it looks after the occlusal reduction has been done properly. So in this area, you can see that some little bit of enamel is still left there, and I have intentionally left that there, and because that I will accommodate that during the proximal tooth preparation. I will accomplish that during the proximal tooth preparation. I don't have to trim that, because if I go to trim that area during the occlusal reduction, then there's a chance that I touch the adjacent tooth. So it's better to it's safe to continue, safe to remove that area into the during the proximal reduction. Now, if you are preparing anterior tooth, the labial aspect of the anterior tooth, now is the time for the labial aspect of the labial reduction of the anterior tooth. In this condition, so after the incisal reduction, so whatever portion of the tooth is remain in the labial aspect, you divide this into 2 halves. The first cervical half is important. It's very important for the retention, and we need to prepare that surface parallel to the long axis of the tooth. So, and the remaining area that we prepare parallel to the normal facial contour of the tooth, and that area is very important for aesthetic. So those two area has 2 different purposes. The cervical part is responsible for the retention, so we need to make that area very much parallel to the long axis of the tooth, and this incisional part, and that is very important for aesthetic. So we maintain the previous anatomy, so that will be parallel to the normal facial contour. So if you see from the mesial aspect or from the distal aspect, your tooth preparation has to look like this one. So during the cervical preparation, we have to hold the burr parallel to the long axis of the tooth. And once that is completed, and once you come towards the incisal edge, then you have to tilt your burr, you have to change the plane, and then you have to prepare the tooth in that way. So the labial aspect will have a 2 plane, one for retention, one for study. So we need to remember this. Sometimes what I have seen is most of the clinicians, they make it flat. So in that condition, the 2 things can happen. One is either they are over preparing the tooth and they lost the retention, or they are under preparing the tooth and they don't have the aesthetic. So that could be the reason. So always remember 2 plane reduction. Those who are not in academic, those who are in clinical practice, they might forget this term. 2 plane reduction for the anterior tooth, labial aspect of the tooth is very important. And another important thing for the labial reduction is when you view from the incisal aspect, your preparation has to have a convex outline. If you see in this picture, this first picture, you can see that the surface is very convex. It is more convex cervically, and as you come towards the incisal, it is little flatter, but still it's convex. So we need to achieve that that preparation. So the reason for this is like to make our restoration very natural, we need more room on the mesial aspect and on the distal aspect. So to have extra porcelain, extra thickness of porcelain on that particular mesial and distal aspect of the labial surface, we need more tooth preparation. And for that, if you want to that extra room, then we need to prepare the tooth in the convex form. In the second picture, if you see that, that's the margin. So this is the margin I have prepared. So if you see above the margin, then there is two plane. So the first one, that is more cervically, it's more convex, and as you come towards the incisal, it becomes a little flatter, but still convex. So that is how we need to prepare this tooth. Maybe if I get time, then I'll show you one video in which I prepare the tooth, and in that video, you'll be more easy to follow all these things. Another thing is like before you starting the level reduction, tooth reduction, we need to decide about this where we are going to place the margin and what type of margin we are going to make. So this thing has to be confirmed before we start the tooth preparation or before we start the level reduction. So if you are making a solder, then you have to use a different type of burr. If you are if you are going to make a long chamfer, then it's going to be a round end taper diamond. And at the same time, if you are making subgingival margin, then you have to plan accordingly. You can't make a subgingival margin and you cannot shift it later on and make it supragingival. You can shift supragingival margin to subgingival, but you cannot bring subgingival margin to the supragingival margin. So this thing has to be confirmed before you start the tooth preparation. And the tooth margin preparation should start from the very early when you are preparing this level reduction. From the very beginning, you have to start to prepare the margin. Don't think that you'll do the all reduction and at the end you will go for the margin. No, margin preparation starts even before the level reduction. So first we have to think about the margin. So here, now that we are talking about the level reduction, so during level reduction, we need to prepare the groups. So normally I prepare 3 groups, one in the midline, mid-facial, and another in the distal aspect, another is in the mesial aspect. So normally I prepare 3 groups, and these 3 groups, if you see it, when I'm preparing the groups on the cervical aspect, I hold my burr parallel to the long axis of the tooth. And as I come towards the incisal, I change my direction of the burr, I change the angle of my burr, and make it parallel to the contour of the facial of the tooth. So that's very important to remember. And so once the group is formed, then I check it with this periodontal probe and confirm whether the depth of the group is sufficient or not. If it is not sufficient, I do it again. I further deepen it, but we need to check it every time. If you want your tooth preparation to be perfect, then don't think that I'm very experienced. I have been practicing this for the last 20-25 years. So this is not important. I have been practicing for the last 20 years and I still do it today also. So this is very important. So once you have made this group, then from the side way, it should look like that one. So the 3 groups they are there: cervical part parallel with the long axis of the tooth, and the incisal part parallel with this facial contour of the tooth. So now these groups are made. It has been checked with the probe, and now it's time to remove this tooth portion in between the groups. So the island in between the groups. So it's time to remove it, reduce it. So what we do is I start from the cervical third, and from the very beginning, I focus on making a margin. I start making thin margin for every time I run my burr from mesial to distal aspect. This you can see in the later on the video, and during this during running the burr from medial to distal aspect, what we have to do is we have to make that surface convex. So we remember this thing. So we have to move our burr, our handpiece in the same fashion, and only then you'll be able to achieve that convexity. Otherwise, it will be either flat or it will be concave. So that's very important. So this you'll notice in my video. So now, if after the occlusal reduction of the posterior tooth, it's now time for the labial reduction and lingual reduction. and the labial and lingual reduction is almost similar in the posterior tooth. So what you do is you make these groups again. You know which methods you are working with, and you know the depth group, you know the final reduction. You have already planned about the margin, whether you are going for a long chamfer or short chamfer. You have already decided it. So just hold your burr parallel to the long axis of the tooth, make those groups, and then finally you will start reducing the tooth. So if you see in the next picture, if you see this actually I have prepared for the student. So it's not exactly how I prepare in my day-to-day practice. Just like what I do is I hold my burr in the mid region, mid buccal region, and then after the group is formed, all those three groups are formed, then I start preparing on the mesial aspect of the buccal side, mesial aspect of the buccal side with my say rounded taper burr. And when I am preparing this surface. As I come close to the proximal aspect, I slowly insert my burr, the tip of my burr towards the proximal aspect and make margin up to here. And similarly, then I go to the palatal surface, and start preparing from the mesial aspect of the palatal surface. And at the same time, what I do is, as I come over here in the proximal area, I insert my tip of the burr more towards the this proximal aspect. So if you see it here, what I have done is I'm doing this buccal and lingual reduction, or buccal or palatal reduction, but I've already started preparing the proximal aspect. So this is how I do it. So in this picture you can see this occlusive reduction has not been done here, but actually I do this occlusive reduction in my day-to-day practice. This was just for the student to make sure that how much occlusive reduction has been done. For that purpose I have left that. Otherwise, normally I complete the occlusive reduction and then I come to buccal and lingual reduction. Similarly, if you see in this premolar here, so what I have done is I prepared all the buccal aspect, and almost I've extended this buccal preparation up to the visual and distal. And here I have made this wing. If you see this one, this is the wing preparation. We call it wing preparation. So in premolars and anterior tooth, normally we need to prepare this wing sometime. And then what we do is similarly I prepare this on the palatal aspect, and I've already extended my preparation to the proximal aspect here as well. Now only thing is remaining is to break the contact. Now, similarly, I do that on the distal aspect as well. And finally, it will be now it's time for the proximal reduction. And in the proximal reduction, so you have already seen that most of the proximal reduction has been already done, because proximal reduction has been already like by continuing this by extending my buccal and palatal preparation. I've already extended it to the proximal aspect. So almost my 60% of the palatal this proximal preparation has been completed. So now only left is to break the contact, and in the posterior tooth I start breaking this contact with the needle sepet burr. And in this anterior tooth, normally I before jumping into this needle sepet burr, I further go a little deeper with this rounded taper burr, and then once almost 50% of this proximal aspect has been prepared, almost this margin, nice long chamfer or short chamfer margin has been prepared there, and then only I use this needle separate bar, needle pointed separate bar to break the contact. Sometimes we teach our students to put some this mylar strip or some protection in between the two teeth, so that will not touch the adjacent tooth. But actually, this is not helpful, because those strips are so thin that once you touch with the burr, it will be perforated, and then finally you are going to touch the tooth. So somebody might find it helpful, but in my practice, I've never found that useful. So I prepare without those protection. So during this proximal tooth preparation, what we need to understand is we need to move our handpiece continuously, because most of the tooth preparation is on vital tooth. So we don't want to damage the vitality of our tooth. So we need to continuously move our handpiece in that arrow direction, so that there will be sufficient cooling will take place. So this you'll see this in the video again. And now let's talk about palatal reduction. So in the palatal reduction, what we need to do is we divide this into two parts. One is singular media and concavity area. So for cingulum area, so what we need to do is we need to prepare that area parallel to the labial aspect so that we'll get a nice retention. In some conditions, in some time, what we do is particularly in our Asian patients, what we do is we get that surface. We don't have that prominent cingulum. So if the cingulum is not that prominent, in that condition, it's very difficult to achieve that parallelism and that to achieve that axial wall parallel to the labial aspect. So it's difficult. But if some patient has this cingulum area prominent in that condition, always try to make that parallel. And for that reduction, what I do is I use a rounded taper burr, and I hold the burr in the mid region, mid palatal region, parallel to the long axis, and from there I make a small groove and then continue that groove towards the mesial aspect, and then again I go back to the midpoint, and then again continue that, and then again move towards the distal aspect. So I finally make that 1 or 2 millimeter thick axial wall parallel to the labial surface. And the now remaining area is the lingual concavity. And for lingual concavity, this American football burr is very, sorry, I jumped. And this American football shaped burr is very helpful. Somebody prefer this donor shaped burr, but I prefer this one. And you just make a groove between this between the center of the tooth, the midline of the tooth here. You just make one small groove over here and then reduce that area. And what we need to do is after the reduction, you check, ask the patient to close the mouth and see in the period whether there's sufficient clearance or not. If in some area the clearance is not sufficient, then you just trim that area and make sure that after the end the concavity is maintained. And sometimes we forget to check this clearance in the protrusive relationship. That is the common mistake we often make. So what we need to do is the clearance should be there both in centriculation or say maximum intercuspation, and this clearance should be there during the protrusive movement. And once this, now we have by this time we have done gross tooth reduction. So now it's time for the finishing. And for finishing, we need this finishing instruments. And normally there are some people who prefer using a fine diamonds, and this yellow coated fine diamonds. And there are some people who prefer this TC burr, tungsten carbide burr. Either 12 or 18 fluted burrs are available. And but I prefer diamond rather than this TC burr. And I have this different sizes, this round, in taper, and diamond, different size. So I use these for finishing. And those who are preparing this solder for them, they also need this end cutting diamond burr. And I've already talked that somebody prefer hand instruments, that's chisel and hatchet. If you want them, they can use them. And there are some people who prefer using this finishing this slow speed handpiece. If you have these facilities in your clinic, if you have this slow speed handpiece in your clinic, and then intraoral, then you can use this handpiece for finishing. Some people in some part of the world, they are also using this ultrasonic instruments for finishing, and but those are very expensive, and we are not used to those instruments. So I've never used that. But if possible, if you have that facility, then you can use that piezoelectric for finishing, during finishing. So what we do during finishing? So what we do is during finishing, we need to round it all those line angles, and we need to check whether the margin is smooth or not, whether the margin is continuous or not, and then you go for smoothing the margin. And if there's any unsupported enamel, then you have to remove those unsupported enamel. And now what we do is, if you see here, sometimes what happens is in some preparation there will be this type of unsupported enamel. If this is there, then it's a problem. You need to remove this, because later on during temporization or during impression or during the fitting of the final restoration, this will break, and then there will be a gap. So from there, they will have a cervical caries. So this portion, this unsupported enamel has to be removed during the finishing stage. So you just break it with your hand instrument, or the best way, the easiest way is you just take a large round round burr, just a large round 2 mm diameter round burr, and just trim that. So with that round burr, you can easily remove that. At the same time, you can convert that into a this long sample. And sometimes what we need to do is we have finished the margin, and sometimes we need to take that margin more subgingivally. And during this procedure, there's every chance we traumatize the gingiva, the soft gingiva. So what happens? What I recommend is whenever possible, you first do the retraction. You first do the tissue management before you start finishing. And that is the safest way. So what happens during the tissue management? Now let's come to the tissue management. So tissue management, here I mean to say managing the gingival soft tissue and the circular fluid, or if there's any hemorrhage, then we need to manage that. And if you go through the textbook, there you'll hear this term subtractive and displacement method. The subtractive method is by using laser and electrosurgery. These are all high-tech. If you have that facility in your clinic, you can use it. But I never thought this technique is superior to the displacement method. The displacement method is very easy, very economical, and it's available everywhere. So I think displacement method using a cord is one of the best method. And still, if you go to the literature, this is the method that is more superior to compared to other. And nowadays there are some European people, they are also using this paste form to retract the gums. And the pastes are very expensive, and it's not easily available. And but even though it's very expensive, but these pastes are not superior to the retraction cord. So the simplest retraction cord is the best. Well, in the beginning, it's quite difficult. Many people find it difficult to place the retraction cord. But once you get used to it, and if you have different sizes of retraction cord in your clinic, then you can easily manage your case. Retraction cord. And mainly, I find three reasons for this. So if you are finishing your margin, during that time, there is a possibility that your rotary instrument might touch the soft gingiva, and then it will start bleeding. So or if you are already prepared epigingival margin, now you want to take it to subgingival area. So when you are doing this, there is every chance that you touch the gingiva with your rotary instrument, and then you traumatize it, and then the bleeding will start. So the safest way to do this is you first retract the gingiva with these different cords, different size cords. And once this gingiva is pushed outwards, then there's enough space so that you can run your burr properly without traumatizing this mucosa. So that is very important. So whenever you are finishing the margin, if it is equigingival or subgingival margin, or if you are preparing subgingival margin, always do the retraction first, and then do the finishing part. And sometimes what happens during this procedure is like the burr comes in close contact with this cord, and sometimes the cord might get displaced. But you can repack it. But normally, if you are using a nice cord, if you are using this either braided or this knitted cord, then they will not wrap around your burr. So it's very easy, very safe. And another reason to use this retraction cord is during making impression. So when you are making an impression, you want your impression materials, your light body impression materials, to go beyond the margin, so that you'll get a nice impression, and you'll have a nice master cast. And so for that purpose, you need to retract the gingiva. So, and not only retraction for that purpose, you need to retract the gingiva and hold it in that place for some time, for temporarily, so during your impression making time, the gingiva is quite out. So for that purpose, you need this retraction cord with some hemostatic agent or some tissue fixation agent. So Sorry, why it's not shifting? So these are the different chords that's available. So if you see in the textbook, these 000, 00, single 0, 1, 2, 3, different sizes of chords are available, and you don't need to buy all these chords. What I do in my practice is like I buy every alternate one. In my clinic, I have a 00 and then 0 and then uh, 1. So I have these three. I don't normally in our patient 2 and 3 are not that much commonly used. So in our Asian population, our people, this mucosa is very thin and this sulcus is very shallow, and that condition is maybe the largest that you can pack without any traumatizing is 1 or 2. 3 is rarely used. So if you have 000, then you can avoid 00. You buy another one is 0. So if you have a 00, then you can avoid 000. So at least you need 2 or 3 of these retraction, 2 or 3 sizes of retraction cord in your clinic, because each patient will need different sizes. And if you go through the textbook, you will see this term: twisted, braided, and knitted. These are the terms when you buy this retraction cord. And normally I prefer to use this knitted one, because in this knitted is when you pull it outwards, you can make it thin. When you extend it, it will be thinner, and during insertion it will be thinner. And once the force is released, then it will recoil back and push the gingiva more outward. So I think knitted, if you have to buy, go for a knitted one. And so these cords are also available in plain or impregnated. They are either medicated. If it's medicated, then we call the term impregnated, or you can also use a plain one. So I normally prefer plain one. I buy the plain one. I also have this liquid hemostatic agent, and I dip those cords in the hemostatic agent before packing this into the sulcus. So if you go through the book, then you'll find this term single cord and double cord. If you go through the literature, definitely you'll find maximum author recommending double cord system. But in our condition, I think single cord works very well. If you are using if your most of the margin is ecogingival, then single cord is enough. Sometimes if your margin is subgingival and your patient has a quite thick biotype and quite wide margin, in that condition, if you can place 2 cords, one the smallest size and one the little bigger one, if you can place those 2 cords, then it will work very effectively, but very nicely. But what happens is when you are using 2 cords, the first cord will remain there even during the impression making. Only the second cord you have to remove while making the impression. So when you are using a single cord technique, everyone recommend you to remove that during the impression making. But sometimes what I feel is if you have placed the cord quite deep inside, and if the cord is not disturbing your margin, if it's quite away from the margin, then sometimes you don't need to remove it. But if you think that your cord is quite big and is in some places it's very close to the margin, then after 10 to 15 minutes, and then you need to remove these cords and just before making the impression. And so now we have prepared the tooth. We have already placed this retraction cord, and this cord has to be there for say 10 to 15 minutes. So what we'll be doing by this time. So this is the time when we can go for a temporization. So the temporary has to be prepared. If you are going to prepare the temporary chair side, then you have to prepare this temporary before making impression. This is very important point, because if you make a temporary before making impression, sometimes what happens after we prepare the temporary and we can evaluate the temporary, and then can find that okay, in this particular region my tooth preparation is little less. I need to re-prepare the tooth or refinish that particular area. So you can judge, you can evaluate by seeing the temporary. And so if you make a temporary first, then it's always safe. And this is the agent I use in my clinic. This is ammonium chloride. There are a lot of materials, a lot of chemical we can use for hemostatic purpose. You can use a ferric sulfate, you can use zinc chloride, you can use this adrenaline. There are a lot of stuff. If you go through the book, you will find a lot of materials, but more or less everything works properly, works nicely. And I think aluminum chloride is the one that everyone, the mostly widely used aluminum chloride, or aluminum chloride is the, I think the aluminum chloride is the best for both hemostatic as well as for the tissue fixation, temporary tissue fixation. So this part is, this is for the temporary. I'm not going to discuss this thing. Then we are already late. We are already talking midnight. So let's forget about this thing. And there are a lot of materials that you can use for making a temporary. And if you go through the book, there are various type of temporary available, from the preformed, metallic, non-metallic, and then from the very expensive light cure materials. So there are a lot of materials that you can use for making a temporary. But this is the materials I use in my clinic. I have all these three. The first one in bottle you can see is Jet Set 4. That is a liquid and powder system. That's and this is just like simply a two-color self-care acrylic resin. And this is one of the cheapest materials that you can use to make a temporary. Those who are not charging a lot of money for the crown and bridge in their clinic, for them, I think this material is perfect. The only problem with this material is like this materials has a very pungent smell. The smell of the monomer, the patient won't like it if you are using the direct technique inside the patient's mouth. And another problem is polymerizing shrinkage. This material shrink a lot when it sets. So that polymerizing shrinkage has to be compensated or controlled. And another important thing is like it's exothermic reaction, the heat. So if you are working on the vital tooth, and if the temperature rises a lot, then that temperature can devitalize your tooth. So that is very important. So I use these materials very frequently in my day-to-day practice. I love these materials. I know how to manipulate these materials. I know how to control the heat. That is, I know how to control this polymerized shrinkage, how to compensate that polymerized shrinkage. So if you know this thing, then it's very easy. And the crown will cost hardly 10 or 15 taka rupees if you are using this material. So it's so cheap. And you can make a crown within just 10 to 15 minutes. And by the time your retraction cord works, your temporary will be finished. So this is a very nice material. I've been using for last 10-15 years in this system, and it works well in my hand. And when my patient is a little hi-fi, and he or she is going for metal-free restoration, and when I'm going to click a pictures for the demonstration in that condition, and then I use this cool temp and Luxatemp. These both are bisacrylic composite. There you will not have any issue with the temperature. There you will not have any issue with the polymerizing shrinkage. Very nice materials. Only the problem is these materials are a little expensive. I don't know how much it costs in Dhaka, but these materials cost about 10,000 rupees for this one single cartridge. So it's quite expensive in compared to that powder liquid system. But it's very good to work with these materials, very easy to work with these materials. And I use all these materials on direct technique. I normally, 90% cases, I make my temporary on direct mouth technique. So this cool temp and Luxatemp is very good. The only difference between the Luxatemp and cool temp is one works with 1:1 ratio cartridge, and one works with the 1:10 ratio cartridge. So, and this cartridge gun is different for both the materials. And just that's the difference. Otherwise, both are aesthetically super materials. Both are chemically same materials. You can easily repair these materials with the flowable composite. I'll show the technique how I do this. And then if you go through the book, you will also find this direct technique, indirect technique, direct technique. So I've already mentioned that I prepare my temporary chair side, and most of the time it's always direct technique. I rarely use indirect technique. I use indirect technique just when I'm making a second set of temporary. Suppose say I'm doing a full mouth job, and I've already prepared one set of temporary using a direct technique. And then the second set of temporary, if I'm going to use in the lab, if I'm going to make it in the lab on the articulator, in that context only, then I go for indirect technique. Otherwise, direct technique works perfectly, perfectly for me. Indirect, direct technique, I never use this technique. because I find direct technique very comfortable with me. So if you have any questions, any queries regarding this technique, we can discuss in question answer session. Just I'm running to fast so that I can finish my presentation on time. If you have any queries regarding any of these steps regarding that I have not mentioned, we can discuss in between at the end during question and answer session. So this is one of the easiest way to make a temporary direct technique with the powder and liquid ratio. What I do is I just mix the powder and liquid in that and just small amount is for the single crown. So just mix a small amount, and when it comes in the dough stage, you just make a small ball, dip it in the cold water. And maybe in Dhaka you need to dip it in cold water, but in Kathmandu it's so cold, so we normally dip in the little warm water. And we dip in the warm water and then put it in the patient's mouth over the prepared tooth, and just adapt it around the tooth, and ask the patient to close the mouth. And then after a few seconds, you'll get this form. Okay, this is the internal form, and then there's some flashes over here, and another side there's occlusal marking. So, and then slowly you remove it from the patient's mouth, dip it in the cold water or warm water according to the temperature. Here we do dip in the warm water, and then again put it in the patient's mouth, and then again remove it, put it in the cold water, warm water, cold water. Then so you play in that way, so that if it is setting very slow, put it in the warm water. If it is setting very fast, put it in the cold water. If this exothermic heat is coming out very rapidly and if it's getting too hot, then put it in the cold water. So you manipulate this thing. So just and keep on removing from the patient's mouth. So if you do it 4 or 5 times continuously, then within 1 or 2 minutes, this metals will slowly start polymerizing, and then completely remove it and put it in the cold water. And let it sit there for some time, and then start finishing. You remove all those flashes here. You can see the margin clearly here. So you just preserve, keep the margin, and rest you slowly trim it, and just finish it. And then check the occlusion here. And then this is how you polish it. If you have some acrylic polishing materials in your clinic, chairside, acrylic boards are available now finishing. So you just use those silicone to polish it. So you just hardly take 5 to 10 minutes to complete this job. So why don't you do these things? You guys need to do this thing, because you can't say your patient after the tooth preparation come tomorrow or come day after tomorrow, and then I'll put it temporary, or I'll make for permanent very rapidly, so no need of temporary. Don't say this thing. Temporary is must, whether it's a vital tooth or non-vital tooth. Temporary is must, and to make this routinely for every patient, you need to learn this direct technique. If you follow the indirect technique or direct indirect technique, then what happens, like you want to avoid it, and then you want some excuses with the patient, and then you'll say that come tomorrow or day after tomorrow I'll put a temporary, or I'll request my lab to do it fast, so that within a day or 2 days I'll give the final restoration. So that's not the excuse. Temporary is must. Believe me, I've also passed from Dhaka, both my graduation and both bachelor, PG and bachelor. I've done it from there, but from last 21 years I'm practicing it. Almost in each 99% patient walk out of my clinic with the temporary. So this is must. So if you don't want to work with these materials, or if your patient is paying you a little extra, then this is the best way to work. This is the easiest way to work with this acrylic resin system. So what you do is, before you prepare the tooth, you make impression. This is a putty impression. So the same putty impression I'm going to use later on for final impression. So what I did before the tooth preparation, I took one impression with this putty, and then I kept it inside, and then started tooth preparation. So after the tooth preparation is over, I placed the retraction cord, and then it's time for the making this temporary. And just take that, put the mixing tip in the front, and inject that materials into the preparation area, and sit the tray back into the patient mouth. And just after 30-40 seconds, you remove it. It will come in this way. Just blow some air with this triple syringe. It will easily come off. Sometimes you might need to little bit pull it out, and then it's here. So the anatomy is here, nice anatomy is here. It's very easy to finish. Everything is very simple method. No pungent smell, no heat, and nothing. So it's very good. Maybe this is the easiest way, but little expensive. It becomes little expensive. The better it's little expensive. So what happened after that? I place it back into the patient mouth, and then I just for this trimming purpose, for shaping purpose, I made this little bit of this line marking here, and then this is another one. The same patient, I this with the acrylic burr, finishing burr, I just finish it, and then my camera is finished. Just hardly take 20, maximum 20 minutes time. Otherwise, if you don't want this very good looking finishing, then you can finish this in 10 to 12 minutes. So it's very easy technique, little expensive, but worth. So I recommend everyone, please go for this technique. So don't let your patient walk out of the clinic without any temporary. So now let's come to the impression. And impression, there are various ways of making impression. There are a lot of impression materials available in the market, but for me, elastomeric is must. The first thing is elastomeric impression is must. If you are working for crown and bridge, no alternate. It's elastomeric impression. So that's a must. And there are a lot of materials, like say for additional silicon, conditional silicon, polyether, polysulfide. Polysulfide is nowadays not available easily, so forget about the polysulfide. Conditional silicon in the past was quite cheap, so people used to. I used this conditional silicon, but nowadays additional silicon and conditional, there's no price difference, not much difference. So now I love this additional silicon. So polyether is there. It's equally very good materials, but it becomes a little expensive with the polyether. Very stiff materials, good materials. But so what I think with additional silicon, if you have additional silicon in clinic, you can use this materials from say from partial denture, crown brace to implant, everywhere. So this is the best material, and this additional silicon you can get in different viscosity. And the putty wash system is the cheapest, I think. Putty wash is the cheapest and easiest technique. So I use this putty wash technique in my clinic almost in all cases. Price is concerned, go for this putty wash technique. It is one of the cheapest way to make impression. And another way is like even putty wash. If you go, there is like you can use a triple tray, you can stock tray. This triple tray you can see in this picture. This is the triple tray, and I'm very great fan of this triple tray because the main advantage of this triple tray is like if you make an impression with this, a very little amount of impression material is being used. So the impression will hardly cost say 100 rupees, 100 taka rupees, 100 taka. So with the very limited amount of impression materials, you can make an impression. One is the greatest advantage. Another is like most of the time what happens, you send the impression to the lab. So your tray will be lost there. So the technician never will return your tray. So if you have this plastic tray, this is a disposable tray, so you don't have to worry about whether the tray will come back or not. It's not important. Not important. The third one is most of the time what happens, our technician, they don't articulate the cast. If you if you start using triple tray without articulating, your technician cannot do the job. So here articulation is a must. So your technician is compelled to do the articulation part. And another important thing about the triple tray is in one shot you can take the impression of the maxillary arch, you can take the impression of the mandibular arch. At the same time, you also have the bite registration. So everything is happening in the single shot. So this is a very good thing. I think this is one of the wonderful things. But this is recommended for only short span bridge or single crown. Actually, only crown. So when you are doing a single crown, for that, this technique is perfect. When you are working with the long span, when you are making impression for the long span, in that condition, you need a stock tray. And even in this putty wash technique, there is one-step technique, two-step technique. Actually, it's a two-step technique. So what I normally do is I make a putty impression first. Once the material sets, and take the impression out, and then do some cutback. Somebody prefer to use with the spacer. I don't like spacer. I just do some cutback. I do the contact from the margin area and interdental area, and then again I mix the light body and put it in the tray and then insert it back into the patient mouth. So that's the way I do relining of the putty, and that works wonderful. And another this advantage of this technique is like even if you are not using retraction cord, this your putty impression will push the light body into the sulcus very effectively. So sometimes even if you don't want to use the retraction cord, or sometimes it's quite difficult to insert the retraction cord in some patient, in that condition the putty wash technique is the putty will just pump or push this light body metals into the sulcus so nicely that sometimes you can avoid that cord technique. So in that aspect, I think the putty wash is the easiest way. But if you are using your monophase technique, or if you are using dual phase technique, that is equally good, no problem. But I think this is the easiest way of making impression. So this is the my case, one of my case. I've done a posterior tooth preparation, and then that is the quadrant tray. And I have used this putty wash technique with the quadrant tray. Normally, if you go through the textbook, this quadrant tray or this triple tray has to be used with the heavy body and light body combination. But I find this putty wash technique equally effective and simple. So I've been using this for the last 10, 15 years, this triple tray. And this. The only difficult thing is this articulating. So without articulating, your technician can't work. So if you don't have this system, or if your lab doesn't apply to this system, then it's not possible to work with the triple tray. So I have my own lab. I do all these things myself. So for that purpose, I have I brought this articulator. This is the quadrant articulator and sectional articulator, and this is the dialogue tray. So that's the dialogue tray for the quadrant. So I have that dialogue tray. So everything is there. So it has been articulated, and I have taught this thing to my assistant. So he can do it very easily. Just take half an hour time, and then the die is there. So this is the end of my presentation, but I would love to answer a lot of questions. I think that there will be a lot of questions for me, and then I'll answer whatever I have missed in my presentation. So thank you everyone.
Thank you, Dipak Thapa, for your nice and valuable presentation. It was really a very enriched presentation, and we are really lucky to be present here. In this night, we expect many questions from the viewers, but you will be sad to hear that in Dhaka city.
We can't hear you.
Hello.
Yes.
Not yet.
Hello.
Yes.
Hearing?
Yes, I can hear you.
Okay.
Yes. Okay. The presentation was very much informative, and for our in our circumstances, I have to add something with Dipak Thapa that we should for the dental practitioner, or we should know the bars. If we recognize the bars, the tooth preparation is very easier. If recognize the bar you showed in the slide, and in addition that we have one more bar that is called torpedo bar. If just the dental surgeons recognize the bars, the tooth preparation is, I think, very easy. Now I am going for the question sessions. First of all, our sir, Dr. Anupam Podder, have some questions. Please, Anupam Podder sir, ask your questions. Anupam Podder sir, please ask your question.
His mic is mute.
Dr. Anupam Podder sir, please unmute and ask your question.
Unmute.
Okay.
Oh, thank you, Dr. Nice and
Sound.
Can you hear me?
Sound problem.
बोलें
Yes,
भैया
yes,
बोलें.
hearing.
Can you hear me?
Yes.
Yes, hearing.
Me?
Yes,
Oh,
yes,
okay,
yes.
okay. Thank you. Thank you, Dr. Dipak Thapa,
Most welcome.
for your nice and elaborate presentation. I think shortly you described much more things that is helpful of our junior dentists that are waiting for this session. Now I have some question to Dr. Dipak Thapa. Uh, in the student period, he is my colleague, and I know his curiosity to invent something, and from he always try to invent something in the course. So I have some question that number one question: if you lost biological weight, then maybe problem in the tissue. How you solve this problem?
So,
In case of you, when you prepared the shoulder
the
for
problem is
anterior.
like so when you extend your margin towards the subgingival area, and so for example, if your this sulcus depth is 3 millimeter, and you can use up to 50% of the sulcus part. So by extending 1 or 1.5 millimeter of your margin into the sulcus will not create a big problem. Will not call it. We are violating the biological weight. As far as you are sealing the margin, as far as your restoration is very tightly sealed with the tooth. But if your restoration is not sealed, or if you have gone beyond this epithelial attachment, in that condition, then it could be a big problem. And now the response of this thing depends on patient to patient. If a patient has a very thin biotype, in that condition, the patient will have a recession of the gum. But if your patient has a thick biotype, then that condition sometimes, even though a lot of our colleagues are not doing good job, but even then our patient are not complaining in the early days. Maybe in the long term, he or she will have a problem, but in the early days, he or she will not have much such problem. So always we try to maintain the biological weight. We have to respect the biological weight. Our restoration should not be too far beyond this epithelial attachment. So if you respect this biological weight, definitely your gum response will be good, and that will help to maintain the long-term this health of the both the restoration for the tooth as well as of the patient. So that's very important. You need to respect biological weight. If sometimes what happened, like we don't have a choice. Our tooth, the height is so for example, a tooth is broken, the height is very less, and for retention purpose we need to go there. In that condition, maybe you need to go for gingivectomy, alveolectomy, and you do the or you do the orthodontic extrusion and bring the make the tooth little longer, and then go for the restoration. So if you can't respect the biological weight, then you have to perform these surgeries, and then you can proceed with your case.
Okay, okay. Thank you. There is another question. What is the limitation of zirconium? For this reason, you are not usually preferred. What is the limitation of
Zirconia is like
zirconium?
zirconia can be used in anterior region. Zirconia can be used in posterior region. There's no problem. As a crown, as a 3 unit, 4 unit bridge, zirconia, tetragonal zirconia is recommended. But the problem of zirconia is, suppose, say for example, your patient is missing central incisor, both the central incisor and lateral incisor. That means 4 teeth are missing. And normally, what we do is we can go for a bridge extending from canine to canine, or from first premolar to first premolar. But if the four tooth are continuously missing, say for example, two central and two lateral, in that context, don't go for zirconia. Even though some brands they recommend you to go for a zirconia, but I personally say no. If four teeth are continuously missing, or there are four pontics to be replaced, then in that context, metal ceramic is still the best. Or if you have to, if your patient is demanding a very high aesthetic, if your patient is demanding for the zirconia, in that context, make sure that your zirconia is tetragonal zirconia. If needed, you go for a layering. No monolithic here. Go for a layering. tetragonal zirconia, make sure that the compressive strength and tensile strength of the zirconia is one of the strongest, best beyond 1300 megapascal. In that context, then maybe you can use it. But normally, more than 4 pontics, not recommended.
I want to add something, Dipak Thapa. You
Yes,
mentioned that you not prefer zirconia for anterior tooth. Why and which material should we prefer? As far we know, zirconia is the most available material and easily available, and we are doing as usual in practice, our daily practice. So
yes.
we
No, when you are just like for anterior tooth, you want most aesthetic materials, isn't it?
you mentioned that zirconia you don't prefer.
Yes.
Yes, you mentioned that don't you not prefer. Which one is preferable? Which one is
Emax.
preferable?
Emax. Go for Emax. Emax is the most translucent material. If you compare it with the zirconia, Emax is the most translucent material, highly translucent in compared to zirconia. There are few zirconia available in the market nowadays. They are claiming that they are equally translucent. They have lots of fluorescent materials in that materials, so they are good. But if you compare side by side with the Emax, you will find that Emax is far more natural looking than zirconia. So now the question is, uh, even
Uh,
if so let me finish it. Even if you are using a cubical zirconia, for engineering reason, everyone is using cubical zirconia nowadays. Those cubical zirconia looks awesome, good, but the problem is the strength of the cubical zirconia is slightly higher than the Emax. With the tetragonal zirconia, it is very high, but with the cubical zirconia, the strength is not that high. So if you are making a crown, if you are making a laminate, then always in the interior region, then always go for this Emax rather than the zirconia. Your lab is recommending you zirconia because they don't have Emax, or they don't want to work with the Emax, because working with Emacs is difficult for the lab technician. Making a zirconia crown is very easy for them if they have a milling system. So they will always want you to pull towards the zirconia. But it's you who have to decide it. This most aesthetically pleasing is zirconia. And another, is Emax. And another advantage of Emax is once it is bonded to the tooth, you will have this monoblock effect. So that for that purpose also always go for Emax when strength is not important. When strength is very important, your patient is a bruxer, your patient has a very strong masticated muscles, the patient is chewing from anterior aspect, the patient has an anterior edge to edge bite. In that condition, go for a zirconia. But when aesthetics is most important, go for a Emax.
Dr. Deepak,
Thank you
here
very much.
there is a problem. The Emax is only for anterior teeth. It is not usually used in posterior teeth. And in case of
You can use for the crown.
short span bridge, it is not possible by Emax in posterior
I
teeth.
don't I don't go
It
for
is
a brace in
only
posterior. I got that.
better in
But
the
for the posterior round, you can use it. Especially there are some condition when suppose say your patient has attrition, severe attrition, and you want to do full mouth rehabilitation. You want to increase the vertical height. In that condition, nowadays there is a term called tabletop. You want to prepare the tooth as a tabletop, not as a crown, but as a tabletop. So there is nowadays we are using tabletop whenever it's possible. So for the tabletop, if your preparation is like tabletop, then Emax is the best because only Emax can be bonded to the tooth very nicely. Rest of this zirconia and other metals doesn't work. So when it is crown, then zirconia. But when you are working as a tabletop or endo crown, in that context, Emax is the best. You can bond it with the tooth, and once it is bonded, but here what you need is you need to ease the ceramics, you need to silence it, and then you need to ease the tooth, and then you need to, this resin cement. So when you are following all these protocol, Emax is the best.
Okay, Dr. Deepak, Emax preparation in lab is very difficult. It needs any
Actually,
elaborate
pressing is
procedure.
if Emax. There are two types of Emax. One is you can press it. One you can mill it. So which type of Emax is available in your lab? If it is press, I always love pressing type. I don't like this milling type because the milling of Emax has a problem because when you are milling a zirconia is very easy because zirconia milling the zirconia that is available as a block is that's like pre-sintered one. So what happens is very soft. You can do it, mill it very nicely with any burr. But in case of this Emacs, it is fully sintered type. So milling is very hard and very forceful. And at that time, this crack, might be developed within the restoration, which will later on propagate in the patient mouth. So whenever you are working with the Emacs, try to make it pressable type, not the milling type, if possible.
Which one is costly?
The lab is supposed costly. I think lab are charging zirconia more than the Emacs. In Nepal, it's Emacs is 5,500 and zirconia is 6,000.
Oh.
Yes,
and it is available in your country?
Yes, both are available. Emacs is in my lab. I have Emacs in my own lab.
Oh. But Emacs in our country
I think
is
it's
not
available.
available.
I think these people from Johnson.
No, it is available.
Yes, Bisuda and Govenda, they have started this Emacs.
Emacs.
Johnson Press.
Bishuda
Yes,
Emacs.
yes.
Oh.
Yes. Okay. Thank you. Question are coming.
Deepak, there is a question from Facebook user. There is a question from Facebook user.
Available
Emacs. That is
only injectable.
Which bar is most preferable for chamfer preparation?
For sample, both for the
there are two questions. One is which bar is most ideal for chamfer preparation?
Round and taper. And
another question is what are the conditions that require subgingival preparation? There is another question. What are conditions that require subgingival preparation?
If your crown height is very less and for the retention purpose you need to have that extra grip, and then only you go for subgingival. Or if the patient has caries on this margin area, to accommodate that caries, then go for subgingival. Otherwise, avoid it. As far as possible, avoid it. Subgingival margin is not good for the patient. Subgingival margin is not difficult to prepare, and even to make an impression, subgingival margin is very difficult. So whenever possible, don't go for subgingival.
But in aesthetic purpose,
on behalf of
subgingival margin is.
I have a question to you.
Yes, sir. For aesthetic, so if you are using Emacs or
during anterior preparation, we should.
Science, sir.
Yeah. In case of aesthetic purpose, we must do subgingival margin, right?
No, sir. If you are using
yes.
If you are using Emacs or say zirconia, there you don't need to make subgingival. If it is metal ceramic, I am coming to metal ceramic. Most of the time, we don't want that dark band. In metal, whenever we are practicing metal ceramic, most of the time we don't want that dark band, and we make our margin subgingival. But the main problem here is like it's not because of the metal. It's not because of the metal that dark band is there. It is because the oxide layer that has been deposited, the extra oxide layer that has been deposited within the metal, that is the problem. So what you can do is you prepare a gingival margin, no problem. So before cementation, what you do is you check the inner surface of the crown. If you feel that inner surface is very dark, you just use your burr, diamond burr, and remove that oxide layer. It's very easy. You can remove it, and by just doing this, your 60% of this blackness band will be gone. So by just preparing this subgingival margin, even though you prepare subgingival margin, you will have that dark band if you don't do this thing. So it's not for the aesthetic that we go for. In the past, what the American and British people they used to do is they used to prepare a tooth in such a way that they used to keep the metal margin even in the label aspect, and that metal margin need to be hidden on the subgingival. But we are not doing in that way. We are doing we are preparing a tooth. We are making a crown with the ceramic margin. There will be ceramic and some ceramic in the margin. So it's not because of that metal is not exposed there. It is the oxide layer that is the problem. So remove that oxide layer. Either do the sandblasting or use some burr in the label aspect margin area. We can easily reduce 50 to 50%.
Okay.
Thank you, Deepak. There is another question. What is
Yes.
what is chisel and knife finish line? Are they practically placed? What is chisel and knife finish line? Are they practically placed?
No,
This is a question
actually,
from another.
I never recommend this chisel and featherweight, because the problem of this chisel and feather margin is, if you are preparing a tooth for gold crown, okay, in gold, what happens? The gold is like, once your crown, once you set the crown, and you take some this little older bird and you burnish with this rotary instrument, you can adapt that gold very close to the tooth. You just if you do this thing, you can adapt it so nicely, so closely, that even if this tooth is knife edge or feather edge margin, it works wonderful there. But when you are working with this base alloy, there it won't work. So never go with the feather edge and never go with this big edge and this knife edge. Another problem with this knife edge and feather margin is, your technician will not be able to find the margin, where the margin is there. It will not be visible in the cast. So if it is not visible in the cast,
That
then
is very much
the
important.
is blind. So don't do that. I never recommend that one. So nowadays, if you are not working with the gold, forget about those two type of margin.
Thank you very much. SM Hasnain Iqbal wants to know that and share with you that alginate is cost effective in our subcontinent region. If we use this material for impression,
Yes,
what
sir,
will be the problem
is
in impression? About alginate. Alginate is available in our subcontinent, also is it available?
Yes.
Why we cannot use alginate in this
Because
case?
the problem with the alginate is the dimensional stability is not that. So dimensional, because of the dimensional stability, even this surface detail, the marginal details, alginate will never be able to record that. So forget about the alginate. Alginate is not an option.
The main problem of alginate is tear strength.
During removal, most of the time it tears. So even if we prepare a laptop,
when it is goes beside the margin and gingiva, when you back it and then
actually
it tears.
On behalf of thank you very much.
One thing is,
on behalf of
I want to say something. Can I have a chance? Please give me a space
yes,
to say something.
Awal, please.
Oh yeah. Thank you, Dr. Anupam, for. I want to give a thanks, Dr. Anupam, and all the organizers for giving me a space here and for inviting me as a panelist here. All research person and panelists are present here. All are the famous and very respected person. So I am very glad to be here, and especially I am very happy to see and hear Dr. Dipak Thapa is my
pleasure,
favorite person. I am a big fan of Dipak Thapa, and all I know about Dipak is a very tireless person. As Anupam said earlier, I found him when we were the student of MS course in BSMMU. I always sometimes I found that Dipak is always overwhelmed with inventing something innovation, but something newer thing. He is not satisfied with the conventional. When we are all the other students are very satisfied with the conventional method or technique, in that situation, Dipak is always seeking for something another tricks or tips. This specialty I always like. This one is it is a very special thing, as I know. Anyway, the presentation was the high class as we expected it, and it was almost same. It is very knowledgeable and abundant of tricks and tips. And question, I have no question. I'm just hearing and learning. But I want to share one thing that I want to share with Dr. Deepak.
Yes.
You know, the prosthetic is not a close-ended answer or question. It is
Yes.
always open-ended answer question. So there is always another method, another choice. If one person think that it is the best, another will be go for another method or technique. It can be happened in prosthodontics.
Yes.
So one thing, for finishing, after tooth preparation, for finishing or tooth preparation, as we know, the surface roughness is one of the main criteria of retention. Uh, can you hear me? I am clear.
Yes, sir. You can hear, yes.
Yes,
Yes.
yes.
Achha. For the surface roughness, for that reason, I politely disagree with Deepak here. For finishing, I will request Dr. Deepak not use the yellow fine grit diamond, but I think red, from my experience, and I can say it. You can use the we can use the red marked, that is fine grit there. If you look that your end cutting bar for finishing the finish line, if you look at that bar, it is red color,
Yes.
and maximum in textbook it is recommended that carbide bar should be used for finishing the tooth preparation, and this carbide bar cannot be replaced by a white color fine grit diamond bar. It
Yes.
should equal, and even you if you you know that age one most popular age 158 012 the bar for the finishing, it is also red colored, you see. So I always prefer to finishing the only elimination or something when you are going to cementate it by after etching or etching material, when you using it for cementation, only that case you can go for the white polishing bar. Otherwise it is wise to use a red color polishing bar for finishing. This my it is Deepak, so that I can
Thank you. Thank you, bro.
anyway, so, everything is fine. I have learned a lot from Deepak in my student life when we are the MS course. You can remember that the orthodontic class. I think you did not forget it because yes, being a teacher cannot forget any such type of bad and unmindful student. Anyway, thank you, Deepak. I am very happy to see you, and hope
It's my pleasure,
I will
brother.
see you again and
Thank
again in Bangladesh. Thank you
you.
very much.
Thank you, Awal sir. We will go to the panelist after the question session. On behalf of general dentist, the postdentists know the protrusive movement reducing the tooth height. But on behalf of general dentist, I have two questions. That is, one is the protrusive movement. During protrusive movement, why should we check the protrusive movement during tooth preparation, especially in anterior segment? Why? Please just tell 2 or 3 points regarding this. Deepak.
So this is say your patient is having this is a maximum intercuspation or eccentric lesion. Okay, so you can see a gap there. You can see the clearance there. But when you ask the patient to protrude the mandible, when you ask the patient to bring the mandible forward, at that time there might not be the sufficient clearance. So if there is not sufficient clearance during the protrusion movement, what happens is like during this ceramic trial or during this occlusal adjustment, then you need to remove that area, and finally what you see, there you see the perforation there. So the clearance has to be there both on the centric and at the same time on the eccentric movement. For anterior tooth, we call it protrusive, but not only protrusive, if it is a canine in this the eccentric movement, that's lateral protrusive, also you have to check it.
Thank you very much. There is another thing during porcelain trial or in all ceramic crown during trial. How we can check the contact point? We postodontists usually know these question answers, but for general dentists, this is very much helpful for a successful prosthesis. Please answer.
How to check
For
the
contact point, how can we check this?
So
Contact point checking.
So contact of the adjacent
Contact
to
point.
occlusal contact.
Yes. Adjacent to.
Proximal contact or occlusal contact?
Because after some days or after some years, usually patient come with the adjacent tooth caries, and failure will be the like that.
So what you have to do is when you are fitting a crown, so what you do is in the beginning, I ask my lab to make the contact little heavy or little extra contact in every cases, so that I will adjust contact on the patient mouth, not on the cast. So what happens if the assistant or your technician adjust the contact in the cast? Sometimes it will be there will be no tightness. So that is a big problem. So what you can do is I ask my technician to do little more ceramic there, so that their contact will be little heavy. And during the trial, what I do is I use this marking paper, thin marking paper, or say carbon paper. So I very frequently use carbon paper. So what you do, you put the carbon paper on the proximal aspect and try to sit the crown. Okay. So during sitting the crown, the marking will be fall on the adjacent the crown. So you trim that area slowly with some green stone, and then again try to sit both on the mesial and distal aspect. So finally, after trimming, your crown will fully seated. And whether the crown is fully seated or not, you can know it by running a probe on the margin area. So if the rest margin of the restoration and the margin that you have prepared comes in contact, very close, and that means your crown is fully seated. And now you take a floss. You take a floss and try to pass the floss in between in the proximal area. So if you cannot pass the floss, that means the contact is too tight. You need to reduce it. And if you can pass the floss very easily, that means you lost the contact. We have to send that work back to the lab, either to add. If it is ceramic, you can add it. And what you need to have is you need to pass the floss with little bit of tightness. If you can achieve that one, that means your contact is perfect.
Thank you very much. It will be very helpful for the general practitioners. Obviously. Thanks a lot. Now I am going to the panelist.
Carbon paper যেটা আমরা লিখতে সবাই ইউজ করি কার্বন পেপার সেই কার্বন পেপার একটু পিস নেবেন আর কার্বন পেপার আপনি কি করবেন যেটা কালারটা উল্টা দিকে আপনি ব্রাউন দিকে পারে ওটার মধ্যে রেখে বসাই দিতে চেষ্টা করেন সো মার্কিংটা ইজিলি আপনার কন্টাক্টে চলে আসবে সেটা আপনি চুজ করবেন দ্যাট ইজ দ্য ইজিয়েস্ট ওয়ে carbon paper works very nicely.
Yes, thank you. Now I'm going to the panelist, Professor Dr. Khurshida Tanzir ma'am. Would you like to please add something or have any query or regarding the presentation, tell something and share something with us?
Good evening, ma'am.
Good evening. Good evening. আমি বাংলায় কথা বলি আমি জানি দীপক বাংলায় কথা বলছে আমার কথা কি শোনা যায়
জি ম্যাডাম শোনা যাচ্ছে
হ্যাঁ শোনা যাচ্ছে
দীপকের সাথে তো আমার অনেক বড় রিলেশন স্টুডেন্ট রিলেশন কলিগ রিলেশন সবকিছু একসাথে এমএস করা রিলেশন যাই হোক আমি বাংলায় বলি দীপক আমরা তো শ্যাম্পার নিয়ে অনেক কিছু জানি তো শ্যাম্পারের শর্ট শ্যাম্পারের লং শ্যাম্পারটা একটু আমাকে বলো
মানে সে শ্যাম্পারটা
what is the difference between short chamfer and long chamfer
লং শ্যাম্পারটা মানে যদি আপনি মনে করেন 1 mm বর যেটা আছে না আমাদের আমরা যেটা বর ইউজ করি 1 mm তার ঠিক মধ্যে 1 mm ডায়ামিটার থাকে রাউন্ড বর যদি এটা আপনার 50% থেকে একটু বেশি ইউজ করলে নরমালি উই কল ইট লং শ্যাম্পার and যেটা আমরা জিরকোনিয়ার জন্য মেটাল সিরামিকের জন্য লেভেল আসতে
জিরকোনিয়ার জন্য
জিরকোনিয়া আর ইভেন ইম্যাক্স ইউজ করতে পারেন। আর সেই জিনিসটা যদি 0.3 কাছাকাছি হয় তাহলে আমরা শর্ট জিনিসটা একই জিনিস, একটু বড় হলে আমরা লং স্যাম্পল বলি, একটু ছোট হলে শর্ট স্যাম্পল বলি। জিনিসটা হচ্ছে কি আপনার এক্সেল সারফেস থেকে আয় একটু রাউন্ডেড হয়ে শেষ হয়ে যাবে।
This is deep chamber. অনেক
sometimes we call deep chamber or long chamber.
We call it deep. Sheila, what is deep chamber? It is, you can call it long chamber, and
deep
ordinary
chamber long chamber,
and conventional chamber. This is the short chamber.
Short chamber.
Okay. I have a question. Another question.
Thank you very much.
Okay. Sheila, বলো, অসুবিধা নেই।
না, থ্যাংক ইউ ভেরি মাচ। অনেক রাত হয়ে গেছে।
দীপক, আমি একটা ব্যাপার একটু জানতে চাই, সেটা হলো তোমাকে আমি বলি, আমি টেট্রাগোনাল যেটা জিরকোনিয়া আমি সবসময় আমি চেন্নাই থেকে করে নিয়ে আসি, আমি অরিজিনালি করি এগুলো। তা আমি যেটা করছি তোমার কিউবিক্যাল যেটা মানে যেটা সেন্টারিং করে যেটা করে আর কি, হ্যাঁ। আর তোমার যেটা ইম্যাক্স আমাদের দেশে হয় সেটা হলো তোমার ওই মেথডে, ওই মিলিং নাই আর কি, তোমার প্রেসি করে আর প্রেসার লেয়ারিং করে যেটা করে আর কি, সেটি আছে। আচ্ছা, তো এখন আমি যেটা একটা ব্যাপারে আমার খুব কিউরিওসিটি, আমি এটা কারোর কাছে সমাধান পাইনি, তুমি জানো কিনা, যে যেটা টেট্রাগোনাল আর একটা হলো কি যেটা কিউবিক্যালটা এটা তোমার কলিশন স্ট্রেংথ খুবই লেস, মানে ব্রিটল, কালার খুব ভালো ম্যাচিং হয়, বিশেষ করে 4-5 এর জন্য, হ্যাঁ, ইটস দ্য বেস্ট। তুমি যদি বলো যে অ্যান্টেরিয়রের জন্য লিথিয়াম ডাইসিলিকেট, দ্যাট ইজ ইম্যাক্স, যেটা এটা বেস্ট সেন্ট্রালের জন্য। বাট আমি দেখি মানে প্রিমোলার, ফর প্রিমোলার্স cubicle is the best. Its color matching is wonderful, but only thing is be careful, লাগানোর আগে যদি কোনো স্পেস থাকে যে ভালোভাবে সেট হয় না, অমনি পেশেন্টকে কামড় দিতে বললা, বাস ফ্র্যাকচার একেবারে 3-4 টুকরা হয়ে যাবে, হ্যাঁ। বাট যদি একবার সেট হয়ে যায় গ্লাসের মতো, হ্যাঁ, যদি সুন্দরভাবে সেট হয়, ইট গিভস দ্য ম্যাক্সিমাম স্ট্রেংথ, লাইক টেট্রাগোনাল জিরকোনিয়া, হ্যাঁ, নো ডাউট অ্যাবাউট ইট। তা আমি জানতে চাচ্ছি, এইটা কি যে একদম একটু ফাঁকা থাকলে ভেঙে যাচ্ছে, এটা একদম পড়ে যাচ্ছে, এইটা কি কিউবিক্যালটাই সেই নরমাল কিউবিক্যালটা নাকি ওটা অন্য কোনো কিছু, এটা আমি জানতে চাই। আর
এমনি মানে গ্যাপ থাকলে মানে ভেঙে যায় সেটা তো না, কিন্তু কিউবিক্যাল স্ট্রেংথটা মানে সেরকম বেশি।
আমার একটা মানে খুব খারাপ অভিজ্ঞতা আছে, 3-4টা দাঁত একসঙ্গে ভেঙে গেল, একদম জাস্ট খালি কামড় দিল আর ভেঙে গেল।
তাহলে মানে
পরে আমি ল্যাবের সঙ্গে যোগাযোগ করলাম, ল্যাব বললো যে এটা যদি হাত থেকে পড়ে যায় বা এরকম থাকে তাহলে ফ্র্যাকচার হয়ে যাবে, এটা একদম সহ্য করতে পারে না। বাট যদি সেট হয়ে যাবে, এটা জিরকোনিয়া টেট্রাগোনালের মধ্যে,
জিরকোনিয়া আপনার যদি স্ট্রেংথটা ভালো থাকলে ইভেন আপনি হ্যামার দিয়ে মারলে মানে না ভাঙার কথা
না, সেটা তো টেট্রাগোনাল
মার্কেটিং ক্লেম যারা ক্লেম করে, কিন্তু সেটা আপনি ঠিক বললেন যে টেট্রাগোনাল হলো। কিউবিক্যাল জিরকোনিয়া এখন যেটা মার্কেটে পাওয়া যাচ্ছে, যেটা চায়না থেকে এরা নিয়ে আসছে জিরকোনিয়া, সেটা মানে অনেক কম স্ট্রেংথ, সেটা অনেক সময় দেখছি কি ইম্যাক্স থেকে কম আসছে। এই জন্য আমাকে ইম্যাক্স বেশি পছন্দ, আমি জিরকোনিয়া থেকে ইম্যাক্স বেশি পছন্দ। একটা তো হলো আমার ইম্যাক্স আমার নিজের ল্যাবে হয়, জিরকোনিয়ার জন্য আমি ল্যাবে ডিপেন্ড হইতো, তার জন্য আমি ইম্যাক্সে পছন্দ করি। কিন্তু আপনি যেটা কথা বলেন, সিমেন্টেশন করার পরে ইম্যাক্স অনেক সুন্দর জিরকোনিয়া থেকে। জিরকোনিয়া আপনার সেটা একটা মনোব্লক এফেক্ট জিরকোনিয়ার মধ্যে পাবেন না আপনি, জিরকোনিয়া মানে ইম্যাক্সে এটা পাবেন। এই জন্য সিমেন্টেশন করার পরে ইম্যাক্স এর স্ট্রেংথ অনেক ভালো।
ইম্যাক্স যদি দাঁত ভাঙা থাকে আর যদি তোমার যদি করা হয় তাহলে আরো ভালো, সেটা ইম্যাক্স এর জন্য।
আমাকে কি হয়েছে কি, একবার একটা পেশেন্টের আমি 6 ইউনিট ল্যামিনেট করছি, ল্যামিনেট করা হয়েছিল, 6 ইউনিট ল্যামিনেট করা হয়েছিল। তারপরে পরে পেশেন্টের মানে একটু কন্ট্যাক্টটা হয়েছে, মানে বেশি হয়েছিল, পিছনে প্যালাটাল কন্ট্যাক্ট একটু এক্সটেনশন, প্যালাটাল এক্সটেনশন ছিল, মানে ওখানে একটু বেশি প্রোট্রুসিভ কন্ট্যাক্ট বেশি হয়েছিল। সেটা আমি ঠিক করতে সময় দেখলাম একটু মানে ক্র্যাক মতো হয়ে গেছিল। তো আমি ভাবছি না আমার এটা রেপুটেশনের ব্যাপার, আমি চেঞ্জ করে নিব এটা। পরে কাটতে গিয়ে বুঝলাম ভাইয়া এটা কাটতে শেষ নাই, বুঝছেন আপনি, মানে পুরা যেভাবে ইনামেল কাটতেছেন সেভাবে কাটতে হবে, মানে সেটা অনেক বেড়ে হবে, মানে it becomes part of the tooth. So Emax is very good. Even if you find a crack in Emax
এই জন্য
crown,
দাঁত যদি বেশি ভাঙা থাকে বা কম থাকে ইম্যাক্স বেস্ট। যদি ইম্যাক্স এর জন্য স্পেস সেটা যদি থাকে দেওয়া যায়, ইট টেকস মোর মানে ম্যাক্সিমাম স্পেস।
সিমেন্টেশনের সময় আপনাকে কেয়ার করে ভিতরে যে স্পেস আছে সেটা তো সিমেন্ট নিয়ে যাবে।
হ্যাঁ, সেটাই।
কিন্তু আমি আমাদের সবচেয়ে খারাপ লাগে কিউবিকল জার্গোনিয়া। কিউবিকল জার্গোনিয়া সেই জিনিসটা আমাদের পছন্দ না।
না, আমি তো বললাম আমি বিপদে পড়ছি। আমি কিউবিকল নিয়ে আসে বিপদে পড়ছি, ওই যে 2 বার একদম ভেঙে গেছে।
কিউবিকল জার্গোনিয়া ইজ নট
Thank you,
color matching excellent color matching.
না কালার জন্য তো ওরা কি করছে, কিউবিকল জার্গোনিয়াকে আপনাকে আরো বেশি হিট করে, ইট্রিয়াম কন্টেন্ট আরো বাড়ায়, ওরা কি করছে স্টেবিলাইজ করা হচ্ছিল মানে কিউবিকল ফর্মে, সো তাতে স্ট্রেংথ থাকবে না।
কিন্তু এই সার্কেল থেকে তো বাড়াতে পারছে না। যদি সুন্দর অ্যাস্থেটিক হয় স্ট্রেংথ কমে যায়, স্ট্রেংথ বেশি হলে অ্যাস্থেটিক কম, এই সার্কেল থেকে কবে বাড়াইতে পারবে ম্যাটেরিয়ালস গুলো? এনিওয়ে
thank you Dr. Awal sir for adding valuable opinion.
আর জার্গোনিয়ার জন্য আর একটা মানে যেটা কথা আমাদের মনে রাখতে হবে সেটা হলো, if that zirconia crown is mechanically polished, if the zirconia crown is mechanically polished, then it is very friendly with the opposing tooth. সবচেয়ে ভালো এটা। কিন্তু যদি এটা মেকানিক্যালি পলিশ না করে, যদি এরা স্টেনিং না হলে আপনার গ্লেজ দিয়ে করে পাঠাই দেয় ল্যাব থেকে আসে, তাইলে মানে সেই গ্লেজটা 2 দিন পরে চলে যাবে, তারপরে দেখবেন অপোজিং দাঁত কিছু থাকবে না। সবচেয়ে এটা এজন্য
মানে ওই যে সাইফুল প্রশ্ন করছিল কেন জিরকোনিয়া কেন অপছন্দ করে, আমাকে করলে আমি প্রথমে এই পয়েন্টটা বলতাম।
If it is mechanical polished, then it is the best material. If it is just glazed, then it is the worst material.
না, কিন্তু তোমার ওটা কিছুদিন থাকার পর ওই পলিশ কিছু থাকে না, এটা অপোজিট টিথের জন্য মোর হার্মফুল।
হ্যাঁ, কিন্তু যদি আপনার পাশ ডায়মন্ড পলিশিং পেস্ট আছে, আপনাদের পাশ জার্গোনিয়া পলিশিং কিট আছে, বেশি লাগবে না, 5-6 হাজার টাকা যদি খরচ করে আপনি কিটটা কিনে রাখেন, তাইলে আবার মানে কোনো প্রবলেম নেই।
স্টিল নাও মেটাল crown or metal occlusion is the metal
porcelain.
No, metal only, not only metal porcelain, metal only. That is the best for occlusion.
Metal is the best, and metal facing just occlusion metal and facing is ceramic as the second choice, I think, and then ceramic zirconia, and anterior for anterior Emax is the best. Emax is the best.
থিওরিটিক্যালি আপনার মানে জার্গোনিয়া যদি মেকানিক্যালি সুন্দর করে আপনি নিজে পলিশ করেন, তাহলে অপোজিং টুথের জন্য খুবই ভালো থিওরিটিক্যালি।
কিন্তু পোর্সেলিনে তো অপোজিং টুথের জন্য খারাপ, সেটাও তো ক্ষয় করে ফেলে, তাই না?
জার্গোনিয়া যদি মেকানিক্যালি ওয়েল পলিশ হয়, তাহলে এর মানে ভিন্ন জিনিসটা ইজ নট লাইক এ পোর্সেলিন। পোর্সেলিন ইজ দ্য ওয়ার্স্ট থিং, ইম্যাক্স ইজ দ্য ওয়ার্স্ট থিং। অপোজিং টুথের জন্য ইম্যাক্স ইজ দ্য ওয়ার্স্ট থিং।
Right.
Thank you, Awal sir, for your nice and valuable opinions. Now I'm going to Professor Dr. Zakir Ahmed Shahin sir to add something or to tell something about the session.
Okay, well, Dr. Saiful, thank you very much. And now I want to give a thanks Dr. Dipak Thapa for his nice and brilliant preparation. Once a time he was my best student in City Dental College, and after that he was my colleague in MS course in BSMMU, and he is a very dynamic and talented boy. For a long time I have seen, and now I want to add something. Tooth preparation is very important for every dentist, because most of the dentists, money earned from the chamber by making the crown, bridge, or fixed partial denture. So it is very much useful and to know the principles of tooth preparation. In tooth preparation, just three or four things. tooth reduction is important, and how much tooth you will reduct from which surface, occlusal surface, labial surface, or lingual surface, and the enamel thickness, how much enamel thickness is there, and another one is the abutment selection is very important. And most of the cases we face in our country, most of the dentists, they when they are making the fixed partial denture, they will doing the root canal in abutment teeth. So it is not good. In selection of abutment tooth, vital tooth is best. So no need root canal unless and until the pathological lesion or any other carries. And another thing is margin preparation. So margin preparation is important. If you do the good margin, then crown preparation will be more good. And temporization is another important thing before going for the final crown. Then temporary preparation is very important. So that's all. With just 3 or 4 points we have to maintain very well. Then we can give very good crown, good preparation of the fixed partial denture. That's the thing. And now I want to thanks our Professor Dr. Humayun Bulbul, our Honorable Principal of Dhaka Dental College and Chairperson of this session, Professor Dr. Abul Kalam Azad, and the Moderator Dr. SAIFUL, Assistant Professor of Prosthodontics, Dhaka Dental College, and the panelist, the Professor Dr. Khurshida Tanzir, Head of the Department of Prosthodontics, City Dental College, and Dr. Fiyadul Islam, Assistant Professor of Prosthodontics, Dhaka Dental College, and Dr. Awal Bhai, he is also my colleagues in the MS course in BSMU, and Rajshahi Medical College Dental Unit Head. And lastly, I give the thanks to Anupam. He is a very dynamic and who gives me this opportunity here. And though he is a prosthodontist, everybody know but now he is the associate professor of periodontology and oral pathology, Dhaka Dental College. So thank you everybody, thank you all. That's all.
Thank you, sir.
Thank you, sir. I think this is a very good contact with each other. All the familiar faces are here. And now I am going to the Professor Dr. Humayun Bulbul, sir. Please tell something about the session, and he is our guest of honor today. Sir, please.
Firstly, I used to give thanks to Axis Dental School for inviting me as a guest of honor to this webinar. This webinar is presided by our Honorable Chairman, Professor Dr. Abul Kalam Azad, Head of the Department of Prosthodontics, Gonoswasthaya, samaj, vittik, Medical College Dental Unit. And today's moderator is very energetic, my colleague, Dr. SAIFUL ISLAM, Assistant Professor, Prosthodontics Department, Dhaka Dental College. It is also organized by Dr. Anupam Podder, Head of the Department of Periodontology and Oral Pathology Department, Dhaka Dental College. Anupam is one of the person who did a lot in this COVID situation. You all are known that Bangladesh Dental Society published 2 guidelines for dental surgeons in this COVID situation, how to practice, how to protect themselves. One is in Bengali and one is in English. Bengali part was the author, Dr. Anupam Podder. We are very grateful to Anupam Podder for this activity. Here, panelist, my beloved fellows, Professor Dr. Zakir Ahmed Shahin, head of the department, head of the dental unit of Dhaka National Medical College, and Professor Dr. Khurshida Tanzir Sheila, head of the department of Prosthodontics, City Dental College, Dr. Abdul Awal, head of the department of Prosthodontics, Rajshahi Medical College Dental Unit, and now missing Dr. SAIFUL Islam, assistant professor for Department of Prosthodontics, Dhaka Dental College. Especially, I express my warm gratitude to Dr. Dipak Thapa. Today's in this webinar, except chairman and me, rest of them are either student and teacher relation, or in the other hand, most of them are classmates also. So far I heard from them, Dr. Thapa graduated from Bangladesh, and he was the student of the City Dental College. Also, he obtained masters in prosthodontics from Bangabandhu Sheikh Mujib Medical Vishwavidyalaya. So we enjoyed a lot today's presentation. He delivered a nice, valuable, and very informative presentation, and this was a first-class presentation. I think, but very interesting session was just now ended. Question answer session, which is excellent one. Many webinar we present, we participate, but today's webinar is very interesting to me, especially not only class 1 presentation, as well as class 1 interactive session also. একটা কথা বলতে চাই আজকের এই আলোচনায়, যারা প্রস্থোডন্টিস্ট এখানে আছেন তারা একাডেমিক আলোচনা খুব সুন্দর করেছেন। এটা শুধু যে বাংলাদেশের প্রস্থোডন্টিস্টদের জন্য যে দীপক থাপা আজকে কন্ট্রিবিউট করলো, আমি সেরকম কিছু মনে করি না। পাশাপাশি আমি মনে করি আমাদের জেনারেল ডেন্টিস্টদের জন্য আজকে অনেক শেখার সুযোগ হয়েছে, এবং আজকে যারা ভিউয়ার আছেন তারা যে পর্যায়েরই হোক না কেন ডেন্টিস্ট্রির, সবার জন্য আজকে একটি ভালো সুযোগ এসেছে। এত প্রম্পট থাপা ডেলিভারি দিয়েছে এবং এত সুন্দরভাবে একটা সাবজেক্টকে এত ইন্টারেস্টিং ওয়েতে প্রেজেন্ট করা, আমি সত্যি অভিভূত। তো আমি একটা জিনিস বলতে চাই প্রস্থোডন্টিস্টদের কাছে, এটা আমার আমি ঢাকা ডেন্টাল কলেজের প্রিন্সিপাল হিসেবে দায়িত্ব পালন করছি। এই কৃতজ্ঞতা হিসেবে আপনারা আমাকে এখানে এনেছেন, আমি ধন্যবাদ জানাই। পাশাপাশি আমি বাংলাদেশ ডেন্টাল সোসাইটির মহাসচিবের দায়িত্ব পালন করছি। এই দায়িত্ব পালন করতে গিয়ে সত্যি মিথ্যা আমি জানি না, আমি শুনেছি জেনারেল ডেন্টিস্টের কথা আমি বাদ দিলাম, এটা আমি আপাতত এই মুহূর্তে রাখলাম, কিন্তু আমাদের বাংলাদেশের অনেক লিডিং বলতে আমি যাদের অনেক রোগী দেখতে হয় তাদের কথাই বলছি। সেরকম প্রস্থোডন্টিস্টদের মধ্যে আজকে যে আলোচনাটা হলো, এই আলোচনার মূল জায়গায় তারা টুথ প্রিপারেশন করে কিনা, বা এই কাজগুলো তারা নিজেরা করার জন্য সচেষ্ট কিনা, বা এই নিয়ে আমার একটু প্রশ্ন আছে। আমি মনে করি বাংলাদেশের ডেন্টিস্ট্রি বা প্রস্থোডন্টিস্টদের এই সাবজেক্টটি এগুলোর জন্য যে জিনিসটি সব থেকে বেশি জরুরি, সেটি হচ্ছে যে এই সাবজেক্ট যেটা নিয়ে আমরা আলোচনা করলাম, ল্যাবের কাজগুলো অ্যাজ ওয়েল অ্যাজ ক্লিনিক্যাল যে এক্সপোজার, এগুলোর ব্যাপারে আমাদের প্রস্থোডন্টিস্টরা নিজেদের মধ্যেই যদি কোনো দুর্বলতা প্রকাশ করে, তাইলে এই সাবজেক্টটি ডেভেলপ করা একটু কষ্ট হবে। আমি কাউকে বিশেষভাবে উদ্দেশ্য করে কথাটি বলি নাই, আমার কাছে হালকা অভিযোগের মতো আছে। তো আজকে এই ওয়েবিনারে নাই বা বললাম, কিন্তু আমি মনে করি যে এই জায়গাগুলোতে আমাদের ডেন্টিস্টরা, বিশেষ করে প্রস্থোডন্টিস্টদের জন্য বলছি এই জন্য যে তাদের জন্য এটা একেবারে ফরজ, অন্যদের বেলাও তাই, কিন্তু এরা যদি এটা ঠিক মতো এক্সারসাইজ না করে
পেশেন্টের ফুড প্রিপারেশনের জন্য পেশেন্টের কাছে যায় কিনা এ নিয়ে কথা আছে। সেই ক্ষেত্রে যে ম্যাটেরিয়ালের কথা বলা হলো, জিরকোনিয়াম নিয়ে ফাইট হলো, বা এই যে অন্যান্য ইয়ে নিয়ে কথাবার্তাগুলো হলো, এই জায়গাটায় মানে সবকিছু অন্যের হাতে ছেড়ে দিয়ে একাডেমিক ডিসকাশন নিয়ে আমরা যদি ব্যস্ত থাকি, তাইলে আমাদের মূল জায়গাটা একটা দুর্বলতা প্রকাশ পাবে। যাই হোক, এ নিয়ে কথা বলার সুযোগ ভবিষ্যতে পাওয়া যাবে। আমাদের এই যে নেপালের থাপা, বহু নেপালের আমাদের এখানে পড়াশোনা করে বিডিএস নিয়ে নেপালে প্র্যাকটিস করছে, পোস্ট গ্রাজুয়েশন করে যাচ্ছে। বাট নেপাল একটা সম্ভাবনাময় দেশ ডেন্টিস্ট্রির জন্য। ইতিমধ্যে তারা যথেষ্ট স্বাক্ষর রেখেছে। আমি বিভিন্ন সম্মেলনে যখন দেশের বাইরে যাই, তখন নেপালের আমাদের এই ডেন্টিস্টদের সাথে আমার যথেষ্ট মত বিনিময়ের সুযোগ ঘটে, এবং আমি দেখি যে তারা তাদের দেশে যে এস্টাবলিশমেন্ট তাদের এসেছে, এটার পেছনে তাদের অনেক বলবো যে মেধার স্বাক্ষর তারা রাখে। তো সেই জায়গা থেকে আমি নেপালিদের নিয়ে গর্ববোধ করি। বিশেষ করে আজকে দীপকের অ্যাক্টিভিটি আমার খুব ভালো লেগেছে। আর বাংলাদেশ ডেন্টিস্ট্রি এগিয়ে নিয়ে যাওয়ার জন্য তাদের ফিলিংস আছে, এজন্য আমি তাদের ধন্যবাদ জানাবো। আর আমি মনে করি যে এরকম সেমিনার, এরকম ওয়েবিনার ফ্রিকুয়েন্টলি ইন ফিউচার হওয়া দরকার আমাদের ডেন্টিস্ট্রি ডেভেলপমেন্টের জন্য। তো এটি নিরবচ্ছিন্নভাবে একের পর এক বিভিন্ন সাবজেক্টে তার মেধা যোগ্যতার স্বাক্ষর রেখে চলেছে, এটি যাতে অব্যাহত থাকে করোনা সিচুয়েশনে, এবং ইন ফিউচার আমাদের নিউ লাইফ অর্থাৎ পোস্ট কোভিড সিচুয়েশন যেটা আসবে, এই সময় যাতে আমরা এই থাকি, এই আশাবাদ আবার thanks to all viewers. Again, thanks to Access Dental School. Stay blessed in situation also. Thanks.
অনেক অনেক ধন্যবাদ বাংলাদেশ ডেন্টাল সোসাইটির মহাসচিব এবং ঢাকা ডেন্টাল কলেজের অধ্যক্ষ জনাব হুমায়ুন কবির স্যারকে। আমরা আশাবাদ ব্যক্ত করতে পারি যে শুধু প্রস্থোডন্টিস্ট না, আমরা চাচ্ছি যে দেশের কোন ডেন্টাল সার্জন কখনো টুথ প্রিপারেশনটা অন্তত নিজেকে রেখে অন্যের উপরে ডিপেন্ডেন্ট না হয়। এটা আমাদের ডেন্টাল সার্জন হিসেবে নৈতিক দায়িত্ব, আমি এটাই মনে করি। এবং প্রস্থোডন্টিস্টদের ব্যাপারে তো আমি 100% বলবো যে স্যার যেটা বললেন নিশ্চয়ই অভিযোগ কারো কাছ থেকে এসছে, কিন্তু এরকম কোনো অভিযোগ কারো সম্বন্ধে থাকা উচিত না। অ্যাজ এ ডেন্টাল সার্জন এটা আমাদের নৈতিক দায়িত্বের মধ্যে পড়ে যায়, তার উপরে আমরা প্রস্থোডন্টিস্ট, আমাদের কথা তো বলাই বাহুল্য। স্যার অনেক অনেক ধন্যবাদ আপনাকে আপনার মূল্যবান মতামত জানানোর জন্য। এখন আমি চলে যাচ্ছি, নাও আই এম গোয়িং টু অ্যাসোসিয়েট প্রফেসর ডক্টর অনুপম পোদ্দার for giving some guidelines, and I really grateful to him to arrange such a program like this. It is very very helpful for the general dentist. Dr. Anupam Podder sir, please add something.
Thank you, Dr. Saifur Rahman, for your wonderful presentation, wonderful introduction. And first of all, I thank our guest of honor, our honorable principal, Professor Dr. Humayun Bulbul sir, for give us time at midnight. It is 2:45 now. So and also great thanks to Professor Dr. Abul Kalam Azad sir. He is a COVID winner, but she present here very nicely, no dissertation. And also thanks to all panelists from Bangladesh, and also Dr. Abdul Awal from Rajshahi, and Professor Dr. Khurshida Tanzir from City Dental College, and Professor Dr. Zakir from National Medical College Dental Unit. And finally, I give much thanks and very much informative session. I think our Professor Principal sir says that it is a very nice session. Our junior dentist and younger dentist enjoy this, and they learn much more things from this. And I hope Dr. Thapa may next time he want to give presentation on the implant. I hope I will give him another opportunity 1 month or 1 month later, and it is your demand, but my demand your is apartment preparation, because our younger dentist cannot do any tooth preparation
Yes.
properly. So I repeat to Dr. Thapa, please, first of all, you present about apartment preparation, and this preparation is needed for our younger dentist. And I give scope the Dr. Dipak Thapa later on. He present on in implant dentistry. I think it is very much important and nice session. In next time, I will give you, you will give me your time for this session. And lastly, I thank to Dr. FC Dental School Bond, who give us opportunity to perform this type of session, and they are all always ready to perform this type of session. And thanks to all, and pay to us to do something for the dental profession, and for this type of session, and in various discipline. Now we going to arrange the endodontic webinar in next week. Then endodontic webinar next week by Dr. Santosh Man Bhandari from Nepal. He is welcome to us, and Dr. Sonali Sharma from Gujarat in next one week after, and then Dr. Satish Sharma from India, and Dr. Ajay Kakar, periodontologist, is coming in next month. It is my online next program. I hope we enjoyed this, and every Bangladeshi dentist enjoyed this. Thank you all. Thank you.
অনেক অনেক ধন্যবাদ ডক্টর অনুপম পোদ্দার স্যার। আমি আশা করছি যে এই ওয়েবিনার আমরা চালু রাখবো ইনশাল্লাহ, কারণ এটা আমি আমাদের প্রিন্সিপাল স্যারের সাথে কথা সুরের সাথে একসাথে মিলিয়ে বলতে চাই যে এই যে আজকের যে প্রেজেন্টেশন, যে কোনো জেনারেল ডেন্টিস্ট যদি শুধু টুথ প্রিপারেশন নিজে করতে চায়, আজকের প্রেজেন্টেশনটার সাথে স্লাইড শেয়ারে গিয়ে যদি দুই একটা প্রেজেন্টেশন আরো দেখে, তাহলে তাকে আর বইয়ের উপর দিয়েও যেতে হবে না। এইটুকুই যথেষ্ট তাকে একটা গুড টুথ প্রিপারেশন করার জন্য। এবং অনুপম পোদ্দার স্যারের কাছে আমরা আশা করব যে এই ধরনের প্রোগ্রাম যেন কন্টিনিউশনে থাকে। আসলে অনেক অনেক ধন্যবাদ জানাচ্ছি সবাইকে। আমাদের সেশন অলরেডি 2 ঘন্টা 37 মিনিট চলে গেছে। সবাইকে অনেক অনেক ধন্যবাদ। এখন আমি চলে যাচ্ছি আমাদের চেয়ারপারসনের কাছে। তার আগে আমি সবার কাছ থেকে বিদায় নিচ্ছি। আমাদের চেয়ারপারসন সবাইকে ধন্যবাদ জানিয়ে তার মতামত জানিয়ে সেশন শেষ করবেন আশা রাখছি। আজাদ স্যার প্লিজ।
Yes, many thanks to all and everybody. Very thanks to Dr. Dipak Thapa for nice and informative and practical presentation. This is very good for all the dentists for this preparation of the tooth and others concept. I can just inquiry to you, just should you use any magnifying eye instrument or for the tooth preparation or not?
Now I am also running on 44-45 years. So now even I feel that I need to buy a loop that is 2.5x for this type of work. Till now, my eyesight is good enough, so I am not using it. For margin, I have already told that I depend not only on my eyes but on the explorer. I feel the margin. So when I'm feeling the margin, my eyesight is till now is good. But I think those who are having a little problem, this dental loop is going to be a very good. I think it's better to get used to that loop But if you are buying a loop, then make sure that it's not more than 2.5x. Because if it's more than that, then tooth preparation is going to be difficult. Maybe for endo work, 3.5 would be better. But for crown preparation, because we need to see the entire tooth and at the same time adjacent tooth. So 2.5, more than 2.5 would be a problem. So 2.5 would be a very good. 2.5 magnification.
Thanks. Yes. Thanks, Dipak. Another inquiry in the subgingival tissue management. What is the best way to tissue management in this case?
So the easiest and cheapest way is retraction cord. So if you can place the retraction cord gently, and if you have 2 or 3 sizes of retraction cord in your practice, so that is the best, easiest way, sir. These pastes are very easy to use, but they are very expensive. This nowadays the pastes are available, and some of the pastes are like clay-like materials, and some of the pastes are even silicon-based, and they are easy to inject. And then you need that cotton cap to and to hold the materials into the sulcus, and you need to ask the patient to bite on it. It's quite good. It's promising, but still, I think the most economical, because for our part of the world, price is very important. We want everything to be more economical, because our patients don't pay like in Europe. So I think retraction cord is the cheapest one, best way, easiest way, with some hemostatic agent.
Thank you. Yes, thank you. Another inquiry from when we are preparing subgingival tissue or tooth preparation, in that case, whether we should take impression in that day, or we are giving the temporization and taking the impression after some of another days or later on.
If you have not, if we have not traumatized the gingiva during this subgingival preparation, then in that context, I think we don't have to wait. But if we have traumatized the gingiva, or if there is a possibility of some gingival recession, in that context, it's always good to wait for some days to make a final impression. And by the time the temporary will be there, and this mucosa or the gingiva will heal according to our temporary. So if you can design a temporary in that way, sometimes we do that. So we do that the gingival contouring and conditioning with the temporaries. Sometimes we have to wait.
How long we should wait? How long we should wait for the play?
It depends upon the case what we are doing. Just like in some cases, if I am doing some gingivectomy and alveolectomy, and then that condition, even sometimes I need to wait for 6 months, 3 to 6 months, 4 months. So it depends upon what type of surgery you have done, what type of conditioning you have done.
But nowadays, if we use laser, then we can take impression that day.
This sir?
If we use laser, you know
laser.
Tissue management.
Laser can be used for two purposes. One,
we can take the impression in that day.
Yes.
We don't have
laser. If the laser is, we are using the laser just to arrest the bleeding, or if we are using laser just to ablate the tissue, in that condition,
just cauterize, kara.
Sir, no. There is a new technique of gingival tissue management. The laser just cut out just below the margin, totally cut out, and then gingival tissue will grow up after insertion of within 2 or 3 weeks. This is a fantastic phenomenon. I just started it this practice.
No, a lot of my friends are using that even in the laser, you are doing some minor procedure with the laser, or sometimes even you can do a major procedure with the laser. So laser, if you are using it for major procedure, then it's better to wait for a final impression.
When only gingivectomy, then we can do the impression or take the impression in the same day. When alveolectomy, it should not be taken in the same day.
No,
I think that like that.
গিঞ্জিভেক্টমি কথা বলিনি, আমি শুধু বলেছি যে রিট্রাকশন কর্ডটা যে ইউজ করা হয়, এটা এখন যেটা করে অনেকেই, সিম্পল ভাবে বলি 2 লাইনে, সেটা হলো রিট্রাকশন কর্ড ইউজটা আমরা না করে আমরা জাস্ট যদি সাবজিঞ্জিভালি যাই, ফ্রি জিঞ্জিভাটা মার্জিনের জাস্ট নিচ দিয়ে জিঞ্জিভাটা কেটে দিই, এটা আমরা মার্জিনটা বের করে দিলাম। দিয়ে আমরা ইমপ্রেশন নিলাম, টেম্পোরারি ক্যাপ করলাম, ক্যাপ করার পরে ওই মার্জিনটা কিন্তু আলটিমেটলি ওটা গ্রো আপ হবে, গ্রো আপ হয়ে সুন্দর হয়ে আবার উইদিন 2 or 3 weeks এটা একটা সুন্দর মার্জিন হয়ে যাবে। হ্যাঁ, এখন এই প্র্যাকটিসটা চলছে, এটা আমি 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 নিজে করেছি দু একটা, এবং খুব ভালো লাগে। এখন আর ওই কারণ যে কথা যত কথাই যে বলুক না কেন, রিট্রাকশন কর ইনসারশন করা ইটস এ গ্রেট, মানে একটা মানে খুব 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 বেশি এক্সপেরিয়েন্স হলেও তাদেরকে মাঝে মাঝে যাদেরটা খুব বেশি ফ্লেক্সিবল না, এটা খুব বদারিং। Sometimes it is not possible.
Makes problem.
কিন্তু এখন সাবজেক্টের মার্জিন তো অনেক
ইউজিং দ্য সার্ভেয়ার।
জি স্যার
do you using the surveyor in the crown or base cases?
না স্যার, সার্ভে তো সেরকম দরকার হয় না,
ফেভারিট ইনস্ট্রুমেন্ট অফ
লাগে না
রেসপেক্টেড
অনেক
টিচার,
কি হয়
ফেভারিট ইনস্ট্রুমেন্ট।
সার্ভে কাজ পার্শিয়াল ডেঞ্চার বেশি লাগে।
হ্যাঁ, কাজ পার্শিয়াল ডেঞ্চারে মাস্ট,
কাজ পার্শিয়াল ডেঞ্চার,
হ্যাঁ সেটা তো ঠিক আছে।
where there is severe undercut.
গ্রাউন্ড ব্রিজে কি হয় মাঝে মাঝে কি হয়?
Another inquiry for me. Yes.
প্লিজ স্যার বলুন।
Yes.
স্যার গ্রাউন্ড ব্রিজে মাঝে মাঝে কি হয়, যদি মাল্টিপল
স্যার another inquiry.
মাল্টিপল অ্যাপার্টমেন্ট থাকলে অনেক সময় আন্ডারকাট থাকতে পারে, যেটা আমরা চোখে বোঝা যায় না। তারপরে আমরা কি করি, একটা মডেল করে মডেলে কনফার্ম
খালি চোখে দেখা যায় না প্যারালেলিজমটা।
হ্যাঁ, সেটা মডেলে ডিফাইন করা লাগবে।
লং স্প্যান
মাল্টিপল অ্যাপার্টমেন্টে অনেক সময় করা লাগবে।
Long span. Yes. In another inquiry, this and the breeze cases, we are using the occlusal table very less than the middle portion of the breeze. But if it is in the single crown or two crown, whether we should reduce the occlusal table or not?
আবার বুঝি না, কোশ্চেন বুঝি না স্যার।
অক্লুসাল টেবিলটাকে কি ছোট করে নিয়ে যাবে কি?
ব্রিজ আর আদার কেসেস
লং ব্রিজে
টেবিলটা
লং স্প্যানের ক্ষেত্রে
নিয়ে আসা দরকার, বা
অক্লুসাল টেবিল ন্যারো করবে,
ন্যারো করবে কিনা, ন্যারো করবে,
হ্যাঁ, টু প্রিভেন্ট
even in the single crown, but is it best or not, বা good, বা
I think it's better. I think
স্যার
একটু রিডিউস, এটা আমরা বলা যায় না অনেক সময় ওভার সাইজ খুবই খারাপ, একটু আন্ডার সাইজ হলে ভালো।
আন্ডার সাইজ ভালো, তাহলে অক্লুসাল প্রেসারটা কম হবে, সো অ্যাবাটমেন্ট গুলো ভালো থাকবে।
না না, এটার ব্যাপারে আমি একটু ডিফার করি স্যার, এটা কিন্তু এখন আর না করা হয়। কারণ হলো আপনি যখন সারফেস এরিয়া যত বেশি হবে, এটা ভুল ধারণা, সারফেস এরিয়া যত বেশি হবে প্রেসার তত কম হবে, পার স্কোয়ার ইঞ্চ বা পার স্কোয়ার ড্রপ প্রেসার কিন্তু বেশি হবে। আপনি যদি এক আঙ্গুলের উপরে দাঁড়ান, আপনার আঙ্গুলের উপরে প্রেসার বেশি পড়বে। আপনি যদি এক পায়ের উপরে দাঁড়ান, প্রেসার কম হবে পায়ে, আর যদি দুই পায়ে চার পায়ে দাঁড়ান তাহলে কম হবে। মানে এটা ওই কনসেপ্টটাকে এখন আউট করে দেওয়া হয়েছে যে অক্লুশন টেবিলটা ছোট করে দেওয়া, এটা এখন আর করা হয় না।
আপনি যখন অক্লুশন টেবিল কমাবেন, ছোট করবেন, ন্যারো করবেন, তাইলে কি হবে, চুইং ফোর্সটা মানে প্রেসারটা তো বাড়তেছে, চুইং ফোর্সটা মানে ইজিলি চুইং এফিশিয়েন্সি পাওয়া যাবে, আর
কম যাবে।
ইন কেস কিছু কিছু কেসে সেটা করা যেতে পারে, বাট র্যান্ডম ইউজ করা যাবে না। মানে একটা সবার ক্ষেত্রে
খাবার দাবারটা তখন অক্লুশাল টেবিল বড় থাকলে খাবার বেশি পড়বে, সো বেশি প্রেসার পড়বে। এই কনসেপ্টের উপর ডিপেন্ড করে।
না, এর জন্যই তো তোমার সারফেস এরিয়া যত বেশি হবে, পার এরিয়াতে সারফেস প্রেসার কম হবে,
এফিশিয়েন্সি বাড়বে।
হ্যাঁ, ইন্টেনসিটিটা বাড়বে প্রেসারের, আরো সারফেস এরিয়া কম হলে
চুইং এফিশিয়েন্সি বাড়বে। কিন্তু আপনাকে বাক্কাল কাজ সেই জায়গা থাকতে হবে, ফোকাস সেই জায়গা থাকতে হবে। আপনি
আরেকটা জিনিস প্রবলেম হবে, সেটা হলো সেলফ ক্লিনজিং ইফেক্ট ভেরি ইফেক্ট করবে এটার উপর, যদি সেলফ ক্লিনজিংটা প্রবলেম হবে।
ক্লিনজিং এর প্রবলেম
মানে যদি তুমি ছোট করি না, আলটিমেটলি দাঁতটাও কিন্তু ছোট হয়ে যায়। অন্য দাঁত যদি একটু উঁচা থাকে, এটা যদি একটু ছোট হয়ে যায়, তাহলে কিন্তু ওইখানে খাবার আটকায় যাওয়ার একটা সম্ভাবনা। গালের সাথে ঘষা লেগে যে সেলফ ক্লিনজিং এর একটা যে দিব্যা বা কালের সাথে
ক্যান্টিলিভার ব্রিজের
but shape should
ক্যান্টিলিভার ব্রিজের যে ক্রাউন ওইটা ছোট হতে হবে, আর নরমাল গুলো নরমাল কনভেনশনাল ব্রিজ গুলো বাকলিঙ্গেল উইথ নরমাল থাকাই ভালো। সেম অ্যাজ অ্যাবাটমেন্ট থাকাই ভালো। সেম অ্যাজ অ্যাবাটমেন্ট কনভেনশনাল থাকা ভালো, ক্যান্টিলিভারের বাকলিঙ্গেল উইথ ছোট থাকা উচিত।
Because another thing, I am very much agree to you that the gold crown or gold using in the oral cavity is the best for the patient and doctors also. I have seen in the when I was a student, and then Mauritius as a student was in our Dhaka National College. He is using the anterior tooth 3/4 crown or something like that in the anterior tooth looks. And other people when I was in practice in the normal, like especially in the old Dhaka men, they're coming for making a crown, gold crown for the anterior tooth to prominent heart. That is using the gold crown. Is very good. Even I am also using the last 33 years in the gold crown with the posterior tooth. It's very real. It is good for
gold is excellent.
Using the gold. Excellent. So in the other country, modern country, Japan and others also they are using the gold.
Everywhere, sir. Everywhere.
Gold
This is the best. This is the best.
Everywhere, gold.
So gold is called the ideal metal.
So
Khandani poribarer metal.
Yes.
Gold.
Yes. So
Khandani poribarer metal.
33 years already. I have a crown using 33 years. Still it is good, very good. Functioning is very nice. So, okay, very nice. Many thanks to Dipak Sharma. He has you have a lot of practical experience and others in this connection. So I am thanking thanks to all these panelists, coordinator, moderator, and also the accidental school, and especially I think thanks to the principal of Dhaka Dental College, Humayun. Rural. He's really, I have seen the first speech my arts. He's also dynamic general secretary of this dental society. So I'm thanking to all these moderators and panelists in this webinar today. Especially many thanks to Dr. Anupam Podder. He is making a lot of things from the long days, last maybe about 1 year almost going on. So very thanks to Anupam Podder for this, to continue these things, and we are gathering a lot of knowledge in this webinar in different session. So many thanks to all these who are hearing this program, seeing this program, and attached with these programs, and there now we are thanks to everybody. Thank you. I want to thank everybody, and so I want to close this session today. Many thanks to everybody.
Thank you.
Anupam.
Okay.
সর্বশেষে অনুপমকে বলতে চাচ্ছি, অনুপম যদিও প্রস্থোডন্টিস্ট কিন্তু সে চলে গেছে এখন পেরিডন্টোলজিতে, সো দ্যাট বেশি ওয়েবিনার অ্যারেঞ্জ করে অর্থোডন্টিস্ট, এন্ডোডন্টিক্স এর। কিন্তু আমরা অনুপমের কাছে বলতে চাচ্ছি, তুমি যদিও প্রস্থোডন্টিস্ট, তুমি তাহলে আমাদের প্রস্থোডন্টিস্টের উপরে এই ধরনের ওয়েবিনার বেশি করো, আমরা সেইটা আশা করি।
আমি সায়েন্সের সাথে আরেকটু অ্যাড করতে চাচ্ছি, সেটা হচ্ছে almost 3 hours এবং nobody is getting tired and very much interactive session this is, so far I know. So it's a request from the prosthodontist to Anupam sir, arrange much webinar about prosthodontic topic. Thank you very much.
Okay, thank you.
Good night.
Thank you everybody.
Good night.
Thank you very much.
Bye.
Thanks.
Thank you, bye.
সবাইকে ধন্যবাদ। ভালো থাকবেন সবাই।
Okay.
দীপক, ধন্যবাদ অনেক।
See you soon.
Good night.
Thank you.
Good night.
Good night, everybody. Good night.